Okay, good morning, everybody. Welcome to our public meeting in public, our first of 2024. I take the opportunity to say Happy New Year to everyone. It always feels a bit late to be doing it this time of year, but just in case I haven't seen people, it's a good opportunity to repeat it. Also, whilst I have the opportunity, just recognise that there are challenging pressures which no doubt will come on to in the system. So I just want to take the opportunity to thank all our staff and colleagues who've been involved in providing care over the challenging winter period and just recognise everyone's hard work and efforts. And I'm sure we'll be talking a bit more about that, but felt important to say that at this time of year. I just want to remind everybody that our meeting is being recorded, so it's going to be available for viewing afterwards. So just to be mindful of that. And welcome any governors or members of the public who are watching our meeting today, or indeed on catch up, I think is the term these days, because that opportunity will be available. Also wanted to say, I think this is Anne's first official meeting as a substantive Chief Operating Officer. So congratulations again, Anne, and really good to have you here in that formal role now.
Thank you.
Apologies for absence. I don't think we've had any. So as far as I know, we are all present here today. And are there any declarations of interest for items on the agenda that we need to note over and above our usual declarations on our register of interest? Okay, so I'll take that as none. So minutes of the previous meeting is paper A. Can I just check with colleagues whether we're comfortable that they are accurate reflection of our previous meeting in November? Everyone content with the minutes? Great. Are there any matters arising that aren't covered in the action sheet? Okay, so we'll take the minutes as approved, and then moving on to the action sheet, which is paper B. The wording of the risks has obviously been reviewed and will be coming to the risk report, so that action is closed. The next actions relating to the estate strategy are not due yet. We are obviously due to have a longer term review of the strategy and our annual plan in March. The revised quality framework, Julia, are you able to comment on whether that's going to be on your agenda for the next quality committee?
Thanks, Krishni. Yes, because this is a really important piece of work, and I think just through timing it came to the board last time first, we're actually taking it into, fortuitously, our 1st of February Quality and Safety Committee workshop. So there'll be some other things, but also that, to look at it in detail because it's really important. Thanks.
Lovely. Thank you very much. That's excellent. So we'll perhaps, Julia, ask you just to report back on progress with that through the assurance report, which rather than keep the action open, if that's okay. And then finally, we obviously had planned an annual update from the Northamptonshire Health Charity. And unfortunately, due to circumstances, we had planned it, and our colleague from the charity was due to attend, but unfortunately, circumstances which were unexpected relating to a colleague at the charity actually has meant that they are, well, I think there was an offer to still come, but we felt in the circumstances, because it related to a bereavement, that we would defer the item to March. So the plan is to come back to that in March. So I just wanted to say that we felt that was the right, appropriate and compassionate thing to agree with colleagues at the charity. So that's the plan. So we'll defer that until our March agenda. And I just want to check with everyone if there are any questions or comments regarding the board's forward plan. I think we've got everything that we are due to have on our agenda today, but just pause a moment in case anyone's got any comments on item C. Okay, so we'll note the position on actions, which, as I suspected, Dawn has concluded all our other business that we needed to cover before introducing our patient story. So I'll hand over to Anne in a moment, but I just wanted to really welcome colleagues that I've met before. So lovely to see you, Dawn, and Nancy. I think we only just saw each other on Tuesday, so nice to see you again. And Farida as well. And actually, I was recalling that the previous time I saw you both was at the Quality Awards, where I think the team had won Clinical Team of the Year, and I think Farida won an award as well, perhaps the Patient Choice Award. So just wanted to remind colleagues that we have award-winning colleagues here present today. So over to you, Anne.
Thank you, Krishni. Well, really pleased to have our colleagues here from our memory assessment team. Really excited to hear about the work they've been doing, and we know that during COVID, or since COVID, we had a real increase in referrals of people reaching out in need, and just looking at how this team have faced that challenge and really looked at innovation to take them forward. So I'm going to hand over to Dawn, Farida and Nancy to take us through this patient story. Thank you.
Thanks, Anne. I'm just going to share it, so bear with me for a minute. Just 1 second. Oh gosh. Have I managed to share it? Not very technical minded. Okay, cool. Okay. And as Anne said, we're looking today at a patient story from our memory assessment service in Rushden and the quality improvement project. So I'm going to hand over. Next slide. Bear with me. To Dr. Jan.
Good morning to you all. I really feel privileged to be here today and to be the part of the team where our common purpose is really to provide the highest quality care within the available resources. I know the theme is patient story, but I just wanted to take audience slightly backwards in the journey in terms of what led to the quality improvement project and what was happening. So I'm pleased to say the project started exactly a year ago. So our first patient we saw on 26th of January. And for people who are not familiar with how the memory services work, we have 4 memory services in 4 parts of the county. We get the referrals predominantly from the GP, but we get the referrals from specialists within the hospitals and other services as well. So we found ourselves in January last year with 200 patients waiting on our waiting list and waiting there for months. And there were many reasons for it. COVID was predominantly one of the reasons, but in addition to that, the implications of the COVID on other services. So usually we have the patient referred, assessed, referred for imaging and other specialist assessments, depending on what the patient's story is. But we had gaps and the breaks in all the parts of the process. So we, as team, including Dawn and our quality forum, so we met, we shared ideas. Prior to that, we had lots of sharing of ideas and discussions within our team how to go forwards. So we had the objectives, we had the ideas, but we wanted to implement it. So we presented ours to the clinical effectiveness team, our project, and we started tackling and having ideas how we are going to address each step. The primary driver was to reduce the waiting time. So it was 8 months. We wanted to reduce it to 8 weeks in 80% of patients within the next 4 to 6 months. The next block was people having to wait for the imaging. So we introduced the step that we thoroughly assess the patient's referrals and assess the need, whether they need scanning at this point in time, whether there was scanning done previously so that we can access it to speed up the process. We used to traditionally do all the diagnosis within the multidisciplinary team setting. We shifted it to our outpatient, 50% in outpatient within the MDT. We changed our team's approach in terms of offering outpatient appointments previously to the people where it was small percentage, but we moved on to offer those as clinic assessments for the people most of the time, apart from obvious reasons if people were unable to attend the meetings. We had lots of team building, lots of team work, and we are pleased to say that the project did attain the predefined objectives, protocols, and actions are in place. We achieved the project results, and we have a plan that it will be sustainable in the immediate and in the short term. But to maintain the long-term efficacy of the team and of the new pathways, we don't inadvertently want to affect the other parts of the service. So we have lots going on and to carry on because we have other teams involved as well. But we don't want to lose the sight from other quality initiatives we have for other teams, which include CMHT, as well as the memory monitoring clinic. So I will hand over to Nancy to describe the story and the patient journey, how they benefited from this project.
Thank you, Dr. Jan. Good morning, everyone. I feel honored to be here to present what we did in Rushden in terms of gathering feedback from, if not most of our patients who came through our clinic between the months of January 2023 right through to August. So I went on a journey when I knew we were coming to the Trust Board to present this story, just to gather some feedback from most of our patients who we saw during the quality improvement project. So this is a story from two of the patients. I must say that most of our patients, from gathering this feedback through IQVIA or I Want Great Care, it was encouraging. The majority of our patients felt really supported and listened to. So kind of like you said, we did. So we listened to them. We listened to their concerns about the long waiting list. Patients were concerned that they were getting into a crisis whilst waiting for an appointment to be offered. They were having to wait 6 to 10 months. And by doing this initiative, they felt that they were happy that they were being assessed in one clinic, in one appointment, living with a diagnosis and a treatment, and it was a smooth transition for them to be given the diagnosis and offered post-diagnostic support within one appointment. One patient said this made a significant difference in reducing the risk and crisis. We were finding that most of our patients were getting into a crisis and we were having to deal with the crisis before we actually assess them for memory assessment. This patient and their family moved on to say it saved them time of taking some time off work to bring their loved ones to the clinic and then having to consequently come back for a disclosure meeting and possibly for post-diagnostic support. So it saved them time to come in one clinic. They were well informed. They felt that we had explained the journey, we had explained the process to them prior to the appointment, because this was different to how we used to conduct our assessments. And we took time in explaining how the process was going to be on the actual day prior to their appointment. And they sort of said they felt that it was going to be a hectic day, but when it actually happened, everything ran smoothly. And just to walk away with this prescription in hand, it made a significant difference in their lives. Don, can you move on to the next slide, please? So a bit of feedback from patient C. They said they felt that it was overwhelming, having an assessment in one day, being given a diagnosis. It kind of didn't meet their expectations of our memory assessment process that we had previously, where they would come for an assessment, given some time to process the assessment, and then having the next appointment where disclosure is given, and then another appointment for post-diagnostic support. They felt that it all happened too quickly. And at some point they questioned how the diagnosis was made. Obviously, this was explained to them. Dr. Jan was there to explain the diagnosis process that we had used, the CT scans that was available, and the assessment process was kind of different. And they just felt that the appointment was too long, waiting to be assessed, and then waiting to see a medic, and then waiting to get the ECG done. They kind of felt that it was a very long day for them. However, it was very difficult for me to actually look for some concerns amongst all the patients that we saw between January and August within the clinic, because most of the feedback was quite encouraging. And it was 1 or 2 patients who expressed some concerns about the waiting time in terms of being in the assessment for too long. And this patient had a different diagnosis and were going to be discharged on that same day. And it just didn't meet the expectations of being held by the trust or by the service for a bit longer, if we had just done the assessment then waited for a disclosure meeting. Next slide, please, Dawn. I think that's going straight into your slide. Oh no, that's mine again. So from my point of view as a manager, in doing this quality improvement project, I had to take on additional roles, clinical roles. So assisting the whole team with managing a small caseload, doing some duty roles as well. So this posed a bit of a challenge in having that increased workload, balancing a bit of diverse responsibility and the need for effective communication with my team, and obviously offer them the leadership that they do deserve. This required me to adapt to new tasks while maintaining a strategic focus on the team, on the dynamics of the team, and the trust goals. I had to perform quite frequent supervision to focus on staff well-being. This was a different type of working, and we wanted to avoid maybe for our staff getting overwhelmed with it. So had to do quite a lot of frequent supervisions, and encouraged people, staff to balance workloads, promoting work-life balance, and just fostering that open communication, having some reflective practice with the groups in our MDTs, which were weekly. And we had focus groups, which we were conducting every 4 weeks, just to discuss what was happening within the clinics, how they felt, the pace and the feedback that we're getting from the patients. They said there was a boost of morale within the team, just watching that waiting list decrease and getting that positive feedback from their patients. They say this, they had job satisfaction. They still feel the same, and a sense of accomplishment. And obviously, this is an ongoing process. We're still focusing on the QI project, obviously, of the referrals, assessment, and treatment. I can only just say that collaboration within the team fostered creativity, it improved communication skills, and just led to successful individual achievement and collective awards for our team. Thank you. Just moving on straight to Dawn.
I'm actually just going to go back because I think my slides were out of sync. Dr. Jan, did you just want to feedback your challenges? Because I think it's important to get that in before I kind of say where we're moving forward to. Is that okay?
Yeah, that's really good. Yeah. So I think the message from the team and from myself is that we really want to emphasize that we have quite a good relationship with our team members and with our managers, in terms of it would not have been possible without everybody's contribution. I came up with the idea that setting up, templates for assessments for both our medical and non-medical staff, and people coming forward and accepting it, and the driver remaining the quality. Quality was at the heart of it, but at the same time, we wanted to make sure that its team comes along. It is us versus you and them. So we wanted to focus on that ethos within the team. and maintain that cohesiveness within the team and remaining focused on what our task is. Yes, there was positive disruption. There was sort of skepticism that whether people will come along with all these new challenges. In fact, we were surprised by one of our staff members' feedback that this way of working actually made her decision to change. She was planning to retire actually due to several reasons, but bringing it to one focus at one place due to her physical health reasons, it gave her a new norm, and she's thriving, she's pleased, and she's continuing to work as well as she used to. So I think that message of leadership, that you are compassionate, you are inclusive, you have a shared purpose, and at the heart of it is that you want to improve the quality of care received by our patients within the available resources we have.
Thank you, Dr. Jan.
No problem.
And then just to kind of summarise and follow on for the last slide, and reflections from me as the head of service and about how we move forward. Obviously, the quality award achievement within Rushden team has given the service a really good boost. So well done. The second bit is within the project, we've worked very closely with Northamptonshire Carers and the Alzheimer's Society. So as part of the project and moving forward, they make contact with patients on the waiting list. And because Rushden team have moved so forward, we've kind of changed that they're now supporting us with post-diagnostic support to the patients. It's in the early stages, so we're waiting to review that and see how that works out. So that's another positive bit. And I suppose just to summarise, the plan is now moving forward that Nancy and Dr. Jan are going to be sharing the learning across the other 3 memory assessment teams. And as a result, we are also going to try and look at further joint working with Northamptonshire Carers and the Alzheimer's Society. I think it's also prompted us just to look at our caseloads and to have a review of our demand and capacity within the memory assessment services, but also within our community mental health teams, because whilst they're in one location, they work together as a jigsaw. So it's really important that we look at both services. And again, on patient feedback, I think we just want to review the processes again and look at co-producing how we move forward, taking on board the feedback we've already had. And then I just wanted to quickly touch on the diagnostic centres, the clinical diagnostic centres. I'm not sure if people are aware of them, but we are hoping to link in with them. The one in the north in Corby and the one in, I call the south, the west, King's Eve, to look at improving our scanning times. So again, we're just waiting to do some further work with these areas to support the process further. And then it's thank you. Any questions?
Thank you. Thank you very much, Dawn and team. Brilliant to hear your story and your experiences of your quality improvement project and its benefits to patients. So I always sort of pause a moment because it usually prompts a whole load of questions from people, so you can slowly see hands going up. So I'll start bringing people in if it's okay with you, and I'll just let you decide who wants to answer the question out of the 3 of you, if that's okay. So and some of these might just be comments, but first of all, Chris Oakes, please.
Yeah, so I'm the director responsible for the older adult services under CQC. So I've visited Frida and Nancy on a number of occasions and heard about this, and also the other community mental health teams down the wards. And consistently, the older adults team, I'd want to say, perform brilliantly, the way they manage things and what they do. And I think this is an excellent piece of work, hence it won the Quality Award. The reduction to the memory service, the leadership of Nancy, and I think also Dawn's overview and leadership of all the older adult services is excellent. So as I say, I've been close to it and seen what's happened. And I think everything they've said is brilliant, but equally, they lead their team really well. The team are really positive. I just wanted to compliment and I think they're quite modest about it all. I think they do a brilliant job, and I just wanted to say that.
Thank you.
Thank you. Thank you, Chris.
Thank you.
Angela, please.
Yeah, thanks. Well, I echo what Chris is saying. You know, this is leadership in action. This is exactly, you know, illustrating what good leadership does in all the different roles to actually improve patient care, but also staff experience, and that's really came across well. So thank you very much. My question is, the team, are you willing to share more around this across the trust? Because I think that's something that would be of benefit. And I think question to Itai and Linda in terms of how do we use this quality improvement work, which is so useful, and are we using it across other services? Because again, you know, I think we can share and learn, and I know you know that, but it's just a great example of it in so many different angles. Thank you.
Okay, shall I let Itai, do you want to come in on that?
Yeah, so I'll respond to Angela and sort of come in with my comment as well. So the first thing I'd say is that you know, quality improvement project was presented to you know, to our clinical audit and excellence community, and there were lots of lessons there where, you know, we've got examples of, you know, long waiting lists in other services such as, you know, our ASD and ADHD service, where you know, a really kind of quality improvement approach and, you know, looking at things from a completely different perspective would be beneficial for us sort of powering through those waiting lists. So certainly, you know, Farida has, you know, volunteered to get involved with other clinicians from other services. What Farida probably won't tell you is that she's recently been promoted to Deputy Medical Director of Professional Standards. So, you know, that's testament to her, you know, performance as a rising medical leader. And I think the work that she's doing, not just, you know, clinically, but also, you know, within our appraisal and revalidation and the quality improvement approaches there, is something that we would like, you know, to see her, you know, spread across the trust. So she's, you know, very closely involved, you know, with our IAMs, learning from, you know, significant incidents, and, you know, having someone with that sort of lens will certainly be an asset to our overall, you know, quality improvement approach. So not just in mental health services for older people, but across the trust as well. So that was the comment that I was going to make, and I just wanted to take this opportunity to congratulate Farida on her excellent work clinically and in her leadership role as well.
Thank you. So I was also going to say that we are in the process of publishing, and because other colleagues from other trusts are approaching because they know about the project ours, and we are in the process of publishing it in peer-reviewed journal. So I had initially submitted the poster for the dementia conference, but then I withdrew. I thought I want to do it in a peer-reviewed journal as a publication. So that is in the pipeline as well.
Thank you.
Thank you.
Thank you, Farida.
Thank you, everyone.
Congratulations.
Thank you.
And I mean, just picking up on that point, I mean, I was going to mention, I think, you know, there are challenges and waiting lists on memory assessment services across other parts of the country. So I think sharing your learning more widely and nationally, in whether it's peer review journals or other, you know, in case studies to share with other, I mean, there might be opportunities across the East Midlands Alliance as well, but certainly I know further afield in the Midlands there are challenges with this particular type of service. So any learning, I think, shared outside the organisation as well, I'm sure would be welcome, because, you know, that's one of our opportunities, isn't it, to spread and share good practice and across the NHS, really. Jo, please, Jo Lancaster.
Excellent. Thank you very much, Dr. Jan and team. You'll see from the chat, I'm not going to repeat it, but absolutely incredible story. Thank you for sharing it. I think the capacity to share is really important, and I'd actually go beyond our trust. I think the Northamptonshire system as a whole could certainly benefit from some of the learning, because I'm sure some of our colleagues in the acute trusts would be really interested to see how you're managing that process of helping people access a service, which is really, really critical to long-term health outcomes, is to get an early diagnosis. So I would advocate going as broad as you can. Just two comments, which are sort of questions as well. In terms of that earlier diagnosis, have you done any longitudinal assessments yet in terms of the impact on the patient's quality of life as a result of that early diagnosis? Because often as you leave these things longer, there other health things get in the way. So it would be really interesting once you have got some time to maybe look at some of that longitudinal stuff. And then the second one was just reflecting on some of your comments about your colleagues and your teams, and just if there is anything that we can learn about staff recruitment and retention, because you've talked very clearly and passionately about the central role of the team in designing improvements. And that empowerment obviously has an impact on how people get satisfaction from their jobs. So again, perhaps if there's anything that we could learn from that and lift it and shift it to other parts of our organisation, particularly where we're struggling with recruitment and retention. Thank you, Krishni.
Thanks, Jo. Do any of the team want to come in on those points?
I suppose I think they're on my to-do list. I think they're things that now we've completed it, we need to share with the other teams, but I think that's the additional work we need to do to go further within the organisation. So it's something that we can look at.
Thanks, Dawn. And I think it is really, I mean, it's interesting because I think Anne Rackham and I had a bit of a sort of conversation pre this meeting that actually it's really good to bring out, I think, the benefits to patients, benefits to staff as well, and the service, so that we get that kind of rounded picture. And I think in this story we really started to see that. So thank you, Anne, as well. Sakib, please.
Yeah, thank you. So I'm Sakib Ali. I'm a NED and the audit chair. I just wanted to say thank you for sharing the patient story and the background. And it's great to see how using QI and improving how the teams work together and improving it both for the patient, but also internally how we learn from it. And I remember seeing you at the quality night as well. So congratulations, and I think it's a great story as well. And it's really nice that other trusts are also looking at seeing what we're doing. So again, great result. Thank you.
Thank you, Sakib. David, please.
Lovely, thank you. Thanks all for a really interesting presentation. I was just going to say, as you bring together your learning and you're thinking about everything that's been achieved, do make sure you give yourself a bit of space to describe the developing partnership bit, the work with Northamptonshire Carers, the Alzheimer's Society, that pathway that comes by having sort of NHS medical support, but also support to families and carers through those charities and partnerships, because I think that is also unique as well in the way of working stuff through, and it's really important to bring out. So as you do that, keep thinking about that developing partnership part of the work you're doing, because that's really, really good as well.
Yeah, I'm sorry. I was just going to come back to John as well as to David. Really, really useful points. But at this point in time, we don't have any data in terms of, because it's really people have been waiting for diagnosis for a long period of time. So we can't claim that we're giving them early diagnosis. So as we settle in and, you know, the intensity of the work goes a little bit down, then we will have the opportunity to focus on those quality outcomes. Yeah, it is just initially dealing with the first bit, and then we can have those, milestones in place. But really, really useful suggestions. Thank you.
Thank you, Farida. Okay, finally, I think Melanie. Oh, sorry.
No.
Yeah, Melanie.
Linda comes in. Yes, thank you. I'm Melanie. I'm one of the non-executive directors. I have met you guys before. One of the first service visits I think I ever did was to Memory Services, and it's an incredible piece of work that you've conducted, and particularly the focus on the well-being of your team. As a well-being guardian, I was particularly pleased to see how much that featured in your overall programme. I just wanted to emphasise as well, David made the point around the partnerships. Great to see the work with Northamptonshire carers, and of course in these circumstances the carers play such an important role, as in so many areas. But I also just wanted to reflect on what you'd said about the two different patients and their different reactions to how their diagnosis was delivered. And notwithstanding, Linda, that there's still quite a lot of work to do in sort of getting those diagnoses to be more timely. The flexibility that we need to show for patients who have very different approaches to how they find out, what they find out, when they find out, that very precious assessment process and the diagnosis that it gives is a really emotional event, isn't it, for our patients? So to see that level of focus on how the diagnosis is delivered, it is really critical and brilliant to see. And that in particular, I would love to see shared across all the assessment services, because you can become a little bit glib and complacent as a clinician, can't you, that you're just giving somebody an update, but thinking of it from the patient's perspective is always absolutely fundamental. So I just wanted to particularly applaud that section. Thank you.
Yeah, thank you very much. I think we sort of kept coming back to the focus that was there, and it is, and majority of the people had benefited, and the person Nancy pointed out, we took on board everything, and that is the way really to learn that yes, in our mind we are doing all the good job and everything is coming positive, that we wanted to find out people's experience, and we can't really work without patients' relatives. Yeah, our teams are such that we can't work without them. But thank you, that's really useful.
Thank you, Frida. Thanks, Melanie. Linda?
Yeah, thank you very much, Krishna. Thank you so much for the presentation. I was really sort of excited when I was listening to you with regards to how this improvement was done. So years ago, I trained as a specialist dementia nurse with the Bradford University, the Bradford Dementia Group. So I was involved in this work. So to see it move to this level and actually look at how that feedback is given to patients with their family, that really inclusive approach I felt was really something that has moved on years from when I was doing that role. So thank you very much for that involvement of families and significant others, because that's key. I wanted to talk to what Angela raised around how we take this forward and share it. I think what really struck out to me was how the approach was taken. So it wasn't about, I'm a medic, I'm a nurse, I'm a service manager, that team element of coming together and then actually stepping outside of the normal role to be able to deliver this whilst bringing the team along. So we'll take that opportunity to invite yourselves to our nursing AHP reference group so that we can start to share it there for other colleagues to then understand this process. We'll do it with all the other sort of groups. So it has already mentioned another one. We'll look that it's shared with psychologists who also have their groups. And I think if we can start to share that with all the practitioner groups, then that will start to actually assist us in taking forward any of our service improvements, because we cannot lose focus of the patient and their family through that. Thank you.
Thank you very much. Thanks, Linda. Any final brief comments from the team? Anything else you wanted to add, Dawn, or anyone, to any of those final points? No, everyone happy? Great.
Thank you very much.
Thank you. And actually, just really before I hand back to Anne as well, and just double check with her before I conclude, but or before we conclude, but certainly just really reflecting that I think it's a really good reflection of our leadership behaviours. You know, if we think about working together, embracing change, and taking responsibility and authenticity, that all shone through from everything you've all done, which is great, and very compatible with, you know, our strategic themes as well, partnerships, building a sustainable service, innovation, quality and care at the heart of it all. So and growing our people. So actually I just felt it resonated for a lot of those reasons. So thank you. And thank you for sharing your story, and I think it's interesting for me, because actually I think I shared this with you, Nancy. I remember going to the opening of Rushden Memory Clinic with Reverend Richard Coles, and it had it all painted and co-produced with the service users, and so actually it's really lovely. I'm trying to picture you all doing this quality improvement project, because that was, I think, my last time I visited there. So yeah, it's a really nice memory. So thank you for refreshing that for all of us. Final comment, Anne, from you?
Yes, yeah, I remember that day, Krishni. It was a good day. But yeah, I just want to thank the team. Going with the relative through this pathway in a different county, goodness, just seeing the compassion and how you've come together and worked together. That teamwork will come through to families and patients, and it's just such an important, compassionate way of working that you've really brought some real innovation. So thank you for, from us and also from our community, that you've made a difference to.
Brilliant. Thanks, everybody.
Thanks
lovely
very
to
much.
see you all.
Thank you.
Well done again.
Bye.
Thank you. Bye.
Okay, well, that set a really positive tone for the rest of our meeting, and I think we're now ready to move on to our risk section. So first and foremost, over to Richard for paper D, please, on the board assurance framework and risk report.
Thanks, Krishni. Good morning, everybody. I'll refer to paper D in your packs, which I shall take as read. I'll just draw out 3 points, I think, to stimulate the discussion this morning. So the first, as you'll note and would expect, we've updated the definition and the assessment of the risks within the BAF since the last meeting. This takes account of the feedback that we received and is the product of quite a bit of work from the executive directors. So you'll find these updated definitions and scores of risks in the appendix to this report. And as usual, I'll happily take any comments or questions on those in just a moment. The second area I wanted to highlight then was the risk management framework. We've undertaken the periodic review of our risk management framework, which, as you might imagine, describes how we manage risk within the trust. This has been considered by the Strategic Executive Board earlier this month and was endorsed and supported there. We've not actually made material changes to the framework following this review. Rather, we've updated the terminology to bring it into line with current practice. So historical references to the organisational risk register, for instance, have been changed to the board assurance framework. So we are, through this report, recommending the framework to the board for its consideration and approval this morning. And then the final area, the third area, is really setting out where we're going next. So you'll forgive my indulgence in the report in spending a moment just to reflect on some of the work that we've been doing over the last year in transitioning from the ORR to the BAF. And I hope that information is a helpful aid memoir. Where we're then headed next really takes account of some of the feedback and discussion we had last time round about the desire for some more robust presentation of some of the evidence from our BAF on controls, assurances, gaps and action. So we've been collaborating with our colleagues at LPT as part of our group work on governance to design an improved, enhanced report format, which should be launching early in the new financial year. So this essentially builds on the approach that NHFT has taken this year, adding in that additional assurance information that we've discussed previously. We will be taking the opportunity at our upcoming development workshop in February to talk about this in a little bit more detail amongst the board. But again, I'll happily take any comments or questions on our future plans this morning. So I'll perhaps hand back to you, Krishni, for any questions or comments on the report, and equally seek the board's approval for the risk management framework. Thank you.
Thank you, Richard. Judith, please.
Thank you, Krishni. Good morning, everybody. Richard, thank you very much for the paper. I really welcome the summary of where we've come from. it's always good to sort of reflect, especially since we sometimes get lost in the weeds of where we currently are and what we still need. So yeah, thanks for that. Couple of comments on the BAF, which I've been sort of reflecting on since the committee stage, actually. BAF 1, I was just wondering if it would be beneficial to include something around improving our existing partnerships, or not necessarily improve is perhaps not the correct word, but something along those lines, because we focus very much on building new ones, but I couldn't really see where our current ones are, you know, our current relationships are being managed. So it's just a thought. Secondly, in relation to BAF 7, again, it's just a reflection. It's perhaps the only one where the risk has a system focus. Now, either we have cast the net too wide in BAF 7, or we haven't challenged ourselves enough in our other BAFs to not, if you like, to exclude the system aspect, the impacts on us as a trust. So it's something I think to consider for the future. But apart from that, I very much welcome the framework document, which is again very clear. I do have some really tiny comments which I will take offline because they're not relevant at the board level. But thank you very much for that.
Thank you, Judith. And I think, did David want to come in anyway? So David, do you want to pick up, obviously share whatever you were going to, but also just that broader comment from Judith about BAF 1, I think it was, and perhaps even the system element, just about whether there was an opportunity to sort of talk about strengthening existing partnerships, not just new ones, which I think was your point, Judith, and system impact. So David, over to you.
Thanks. So if I do the Judith questions first, and then I'll come to the bit I was going to say. Judith, thank you. We'll go away and have a look. I wonder if the word actually might be to swap develop for evolve. What we're trying to recognise is everything keeps, so new partnerships, if we take mental health, learning disability, collaborative is an existing collaborative, we're constantly looking at doing something new, we're constantly looking at evolving, taking it forward. So I'll take that to try and feed those bits through. I think I'd say on the system point, while BAF 7 specifically talks about Northamptonshire, I think I'll focus on BAF 1. Actually, there's a system role within that the partnerships and the collaboratives that we are doing are with others. So implicit within the work that we're doing are system things. And I think there's times where that comes through in terms of workforce resourcing strategies. I know that Chris isn't thinking it's workforce resourcing that we do in isolation without talking to the people board and the organisations and the ways of going forward. So I think there is system there. We'll have a reflection afterwards about whether we need to put more in it. The other point I was just going to make is that in the conversations we've had with Richard, I think 9 BAF priorities is very, very helpful for the subsequent conversation we'll have about strategy and the ways forward, and getting a kind of clarity about a focus on strategy, a clarity on our board assurance frameworks. And I think, you know, you end up with 9 board assurance key areas, you can end up with a similar sort of focus around strategy, and bringing them together, I think, will really help that clarity of vision and direction that the trust is going in.
Thank you, David. Julia, please.
Thanks, Krishni. Richard, just want to recognise the journey that I think you've taken us all on to get to this point. I mean, there's been a huge amount of work behind the scenes. And I think for me, one of the things that I take very strong assurance from is the work on the corporate risk register and divisional risk registers that underpin these strategic risks. They're not in isolation. They're a culmination of, you know, many risks sitting below that. And the work to improve that and to make that clearer, and your explanation and your history in the paper is actually really, really helpful, and an acknowledgement to the exec team behind it who regularly deep dive these risks that sit below it, and that feeds into our assurance. So thank you, everybody. I think a huge piece of work and well received, and look forward to sort of going forward in the future, really.
Thank you, Julia. And before I bring Richard back in, Richard, I might as well let you have the last word. So I might as well just say a couple of things. One very small point. You rightly highlight that obviously the staff capability element will be looked at through the lens of the Assurance Committee, and just it reminded me that actually normally we would have the Integrated Assurance Committee's report on our board today, but we were not able to because the timing of it meant that it was literally on the day the papers were due to land. So we're going to have a verbal report from Tim today, but we haven't got the assurance report itself. So I just wanted to explain that, make sure everyone recognised why that was. And just a broader comment, really, I do feel, and notwithstanding the sort of, tinkering that we might do to clarify these further, I do feel these are there's a step forward in terms of the clarity, the thinking behind these, the broader kind of the broader perspective they bring. So I felt this was a really good step forward from the last strategic risks that were presented in terms of clarity and helpful in terms of thinking. So I just wanted to reflect that, really. So thank you, Richard and colleagues. So Richard, back to you.
Thanks very much, Krishna. Yes, I'll keep this brief. Thanks very much, everybody, for your comments. It's really been a good team effort, I think, not just a team effort amongst the management team, but also we've had some really helpful challenge and input from our NED colleagues as well. So I'm certainly feeling positive about where we are and where we're headed. And I think just to the point about some of the wording of the risks, I think really for me, some of the actual specific wording of the risks reflects the wording of the strategic objective. So where we're talking about system work or new things, that's reflective of the developmental objective that we're doing. As you say, it's really important that we don't then miss the operational reality of making good and excellent what we're currently doing. And as we do some of the work that Julie's alluded to in mapping those operational risks across, we will then really be able to see some of the combination of the developed work and the existing work coming through in future BAF reports. So yes, more on that to follow in February, but thanks very much, some really helpful feedback.
Thank you, Richard. So I think the board is asked to consider the board assurance framework. Obviously, there's a further bit of feedback that will reflect in the minutes, and ask colleagues to just consider. But we are asked to approve the refreshed risk management framework, which was associated with the document, and I think that was really just some relatively small changes, Richard, to reflect the development of the BAF as opposed to the ORR. So we do need to formally approve that, if that's okay with everyone. Take that as a yes. So thank you very much. Thank you, Richard. So before we move on from our risk section, we have a couple more items. One is our verbal update from Anne on system-wide winter risks, really. Anne?
Yes, so this winter has been a challenge so far. I think since we last met, we've had winter, we had a period of industrial action, and the Christmas holiday period running into this month. So it's been quite a stretched system, not just locally but also nationally for our preparedness, really. What we were able to do was to meet before Christmas. Angela and the other chief execs, the chief operating officers, met to just really be clear about what things we were going to put in practice to be able to manage this winter period going through. And that was really helpful because we were able to stage a load of developments to be able to manage that, particularly the industrial action and then moving into winter period. So that was really helpful and kind of underpins a lot of the processing we're doing around our urgent and emergency care strategy, so that we have an ongoing foundation plan moving forward as a system, and that's really built around how we increase the flow, enable people to be able to get the right access to services, but also really think about where those flows are happening, what can be prevented managed in the community, how do we enable people to have the shortest amount of time in the hospital, and then the community care that follows after that. So I think that just shows the commitment that the system having on making sure that we are as prepared for every winter because it comes every year. At the moment, we're seeing quite a pressured position where there's an increase in respiratory disease need requiring respiratory infection requiring hospitalisation. So there is a lot of pressure. We've managed as a system to maintain and not move into critical incident scenario, although it's been hard to keep that line with the amount of pressure that's come in through the front door, particularly of our ED departments. But I think we're seeing a really good system response, working very closely together, working on solutions together, and ensuring that we try and work towards some of those pressures, particularly around ambulance handovers and how we get people to not get to that point of emergency. I think that's about all of it at the moment. There's a very strong focus from NHSE on our emergency pathways and making sure that there's a flow in the system. And we welcome any sort of support they can give to the system, as I'm sure others do as well, just to make sure that we are doing everything we can to maintain where our position at the moment.
Thank you, Anne. Just want to check whether anyone's got any other comments. Okay, thank you, Anne. We'll hand over then to Tim, please, for his verbal update from the Integrated Assurance Committee.
Okay, so we had a good meeting. It was last week. Just going through, and I'm using last board meeting's report actually as the pro forma for it, because actually most of the subjects overlap. In alerts, we still had agency spend, so reporting that as the big risk. The risk report itself, though, BAF 3 and 4 in particular, we moved from advise to assure, which reflects the conversation we've just had with Richard about the report itself. Monitoring work for safeguards remained at assure as well. We then had papers on bank improvement projects from Chris, which we graded advise. We had a really good presentation on changes to UK visa requirements, which was assure. Linda presented monitoring work for safeguards, and we touched on assure. And then we did a deep dive, which is a presentation done on workforce race equality standards and challenges in terms of bullying and harassment and non-reporting. Easy to say when you're reading it off the page. It was a presentation, not a report. It was got into a really good discussion, actually. The headlines showed some really good work being done. I think in the future, Chris and I will pick up afterwards about how we present the information, because there was a lot of information to take in the meeting. But it was a really good presentation and a really good discussion afterwards. And that's everything I've written down today.
Thank you, Tim. Always difficult when you're having to do it verbally, I think, as opposed to having the report. But we'll obviously share the formal report for the next meeting, won't we? And so we might end up having two, Richard, I think is what we said. But we felt it was important that Tim had the opportunity to comment, and obviously bring colleagues in who might have been part of that discussion in case they want to add anything. So first of all, Robin, please.
Just to follow on from that, I think it's worth saying that the commitment to tackle incidents of racism involving patients and staff was developed in the context of a really helpful strategy and approach. And I think it's worth highlighting to this board and to observers of this board how valuable and how strong that commitment to tackling those issues is. And we were presented with a very comprehensive report, which I think sets out a very strong agenda for how we're going to tackle this in the future.
Thank you, Robin, and I'll bring Chris in a moment. It's probably timely just to mention that Angela and I and several other colleagues were at a Together Against Racism joint event with LPT, and that sense of clarity about what we were going to, what's in our plans, what actions, the governance, the structure around what we were going to do, which actually address not just our staff, but and support for our staff and for them dealing with racist abuse, but also in relation to patient service users and also our community. So I found it incredibly enlightening, really, in terms of that sense of clarity about what we were actually going to do next. So I don't know how much, Chris, you shared at the Integrated Assurance Committee that aligned with that, but we were obviously together on Tuesday when and you led that event. So you might want to comment on that as well whilst you have the opportunity. Over to you, Chris.
Yeah, we didn't talk. We mentioned the TAR work in the IAC, but it was much more on the res. And as Tim says, we did go through a lot of assurance and detail. And we will return to that. But yeah, as I say, I agree. I think it was great to see people's commitment to it on Tuesday. I want to make more of a governance point, really, Krishni, so I didn't want to lose it. I was conscious of going back to the original discussions about how we considered workforce and the development of the IAC, and I was remembering your words that you saying the board's didn't see a problem with its assurance on workforce, but where was the governance? And I think timely with Tim's comments, now with the strategic workforce group, we've now got a number of other groups, such as the workforce planning group, and then the IAC itself. I think the board can be assured that we really have started to develop a really good governance framework for the workforce issues, for it to be considered, looked at, assurance to be provided, and an appropriate challenge given. So I just, I think that's a journey we're on. I was talking to Julia about it as well, but I think it's useful to remind ourselves that we've developed that and it's bedding in.
Thank you, Chris. Okay, so I think we're just noting Tim's update with the view that we have the formal report for the next meeting, but helpful to reflect on the update and the other comments that colleagues have made. So that concludes our risk conversation section today, and we move on to the strategy section. So we start with the environmental analysis, which is really an opportunity for Angela and executive colleagues, if desired, to just share any perspectives of any sort of emerging things in our environment at the moment. So over to you, Angela.
Yeah, just a couple of things, Krishni, just to highlight. So in terms of the Integrated Care Board, Dr. Imogen Stavley has now been appointed as the interim Chief Medical Officer, replacing Matt Metcalf. So again, many of us have now met her, but I think that's important appointment for the board to be aware of. She's a GP by background, so that position has been filled on an interim basis. In terms of CQC, I think important to share that Brampton Hospital has now received its overall Care Quality Commission report following inspection, which is about 7 months ago now, I believe. That has been rated inadequate overall, which is a deterioration from requires improvement. Just remind people that is run by Nottinghamshire Healthcare Trust. Now, clearly, with it being 7 months ago, I think obviously lots of improvements are underway, but I think important for us to be aware of that nevertheless. Anne's already mentioned the focus on urgent and emergency care in Northamptonshire. Just to say that in Leicestershire, the UHL has been on a critical incident, still on a critical incident today, so the system is responding to that, and clearly LPT is doing that. So that just gives you an example of a very close system to us, where it has moved to that critical incident stage in the acute sector. And that's all. Thanks, Krishna.
Thank you, Angela. Any other comments from anyone else? No? Okay, thank you. So just moving on then to my chair's report. I really wanted to take the opportunity, I'll take the report as read, but to highlight really the quite significant governor election process that will be launching shortly. You'll note in the paper the number of seats that are up for election. Now, obviously, quite a chunk of those people might be people who choose to re-stand for election. So, a number of people, existing governors, terms are coming to an end. So that doesn't mean we'll have a complete turnover in those seats, but we may well have a significant turnover, and that's about half our councillor governors. So it's just really worth bearing that in mind, because obviously, we welcome the opportunity to work with new governors, we will need to support those new governors in their onboarding process, etc. And the conversation we're having really is about a really good comprehensive induction event, which, you know, similar to the one we tried for the first time with governors. Was it last year, Richard? I'm a slightly lost track of time, or a couple of years ago, but no, that worked really well. So we'd like to bring new and existing governors together in a sort of more informal induction setting before the first council meeting they attend. So just wanted to highlight that. Also wanted to highlight, because I think it's important for executives to be aware that there are 5 staff governor seats going this time. But for the first time, we don't have any rules about who can stand. In the past, we've always said for staff governors, you actually need to be we need one medic, we need one nurse, we need, one of these roles. But actually, these are now open to anybody. So if you're out and about and you see somebody who you think, oh, that person would make a good governor, please encourage them to stand. The point of this is really to encourage, good engagement from staff, and actually bear in mind also that staff are now, what's the term, Richard? I think automatically, they're by default, they are now members as well of the trust. So that means they can also vote. So I'm really hoping that this will sort of encourage more staff members to become governors, to play a slightly different role. Certainly colleagues like Richard Amponza, I think, have really enjoyed the opportunity. At least I hope he would say that. And it's good development, I think, for staff as well. So just mention that. And also just wanted to mention on a practical note that we agreed with the council that we're rescheduling the councillor governors meetings to alternate months from the board, and that's so that we can, following a board meeting, making sure we present more timely information to them and assurance. So that'll be in the corporate calendar, but it's just it's very different to what we're used to, because we've normally had a councillor governors meeting a couple of weeks before board meeting, and now it's going to be an alternate month. So just to be aware that does initially create a little bit of a gap between our March council and our June council, but that's where we want to insert this comprehensive induction event, so we can bring all of our new governors together with our existing governors to really sort of build a council from May onwards. So yeah, that's really all I wanted to bring to your attention. I've also mentioned the Together Against Racism workshop, which I was particularly pleased to attend on Tuesday. Had really good engagement from all parts of our group, and it was lovely to see lots of different staff members there as well. So, and I'm sure Angela might want to mention that too. So just for noting really my report, and unless there are any questions or comments, I'll hand over to Angela. Or Scott first, please, before I do that.
Not a question, Krishni, but just a very brief comment to endorse what you were saying a minute or two ago. I think definitely, I think we've all had the experience of how much value staff governors like Richard and Joanne bring forward. I'm just singling those out. Of course, there are many more, right? But absolutely, I think that sounds like a fantastic opportunity to really cast that net and take that perspective and insight that they kind of uniquely can bring forward. So, I think that's a really good opportunity, and, absolutely endorse what you were saying about needing to make sure that we play our part and make sure it's grasped correctly.
Thanks, Scott. Thank you. Julia?
Thanks, Krishna. You'd be really pleased to hear. I've got 2 comments, but Scott's just beaten me to the first one, so thanks, Scott. That saves time. And the second one was just a quick mention about the Together Against Racism conference that you mentioned there earlier this week. Incredible positivity in the room. And I think for me, having been in the NHS many years, the difference for me was it felt as though everybody there, from team leaders, one of our governors attended, a huge variety of different people, different roles, different parts of our communities. Everybody felt that the way it's being organised into a framework really could make a difference. It wasn't a tick box, this is going to, you know, like another framework. It really genuinely felt a positive event, and I know there's a lot of focus, and just to share that really, that there were just a breadth of people there who can actually on the front line make a difference, which was, you know, to families and people in Northamptonshire. So really good event, and look forward to that continuing.
Thank you, Julia. Probably useful actually if we maybe circulate the slides from that event. Probably something I could easily do to certainly to non-exec colleagues, Chris, because I think everyone would welcome that. And I think the particularly helpful bit was the standards. I think that having really clear standards that we're aspiring to, that we can measure ourselves of what, you know, what does good look like. I felt that was really helpful. Chris?
Yeah, I think obviously I've been centrally involved in it. I think what I took away from it, and sort of building on what Julie was saying, I think, yes, we share the slides. I discussed with Angela that quite a lot of people came up, and now it does, which came out of our board discussions. You know, let's remember that everybody said it needs to feel more like a program. Is a lot of people were saying, oh, and this is the way this is shaped. Can we go and share it with our teams? Can we talk to colleagues? Can we share that out? And you know, we can pick that up with Dion. But I think it's important that we share what we're doing. We often think we need to finish it and share that we did the work. Actually, I think increasingly I understand in this whole arena, you need to be sharing with people that you're doing things, because and particularly our ECM colleagues are in that space of, well, are you doing anything about this? And you may not have completed it, but if you can share you're doing it, and as we've now got a whole organisational framework, people buying into it and saying they wanted to do that, I just felt really positive about people's reactions to the whole project.
Yeah, and I think it plays to the point, Chris, that I think one of our staff members, ECM staff members mentioned, which I thought was incredibly powerful, was how do we engage people who are not in the room? Because the people in the room were already engaged and enthused and wanted to support the event. And, you know, how do we make sure that everybody understands what we're doing and can play their part really and extend that? So definitely need to think about that very carefully. But certainly we can make sure that all our non-exec colleagues would, I'm sure, welcome seeing slides, which is easy enough first step for us to do. Thank you. Over to you, Angela.
Okay, thanks, Krishni. So I just want to start by just saying thank you to all our staff, because as you mentioned, Krishni, the sort of pressures, and we've talked about urgent emergency care, but I think it's fair to say that demand's high generally. So it's across all services, and that means clinical and corporate services. It's not just owned by our clinical services. People have responded, you know, to industrial action. You know, people have worked over Christmas, New Year. Pressures are ever present, but I think what we can be confident of is that staff go above and beyond, and that is really something that we should never take for granted. But it's important, I think, to thank people for that, because it does make all the difference to us. So just a few other things that I wanted to highlight. You'll see in the report that I've mentioned the Care Quality Commission's new assessment process, and it's just to remind colleagues really that that is very much now imminent and upon us. So we do expect to, from the 5th of February, start to be moving towards that in our particular area. Obviously learning to do, because it's a new system for Care Quality Commission, it's going to be new for us. It is, though, still very much fundamentally based on the key lines of inquiry. So it's not a shift that we won't recognise, but it's important that we do recognise it will be quite a difference for the trust in terms of information that's requested regularly through that. But I am pleased to say that Craig Howarth has agreed to come to our joint board session that Richard's already mentioned in February. So that will be a great opportunity for us as the two boards to come together and to get early insight into what that means. So we can look forward to hearing more there. Again, we've talked about partnerships already this morning, but I think just to highlight again in the report, the new partnership with the University of Leicester, which will take us into new opportunities. I know ITI in particular will welcome this and be, you know, working with David in terms of how do we really now embrace this across NHFT, but also across the group, working with Banu as well as medical director there, because this does represent new opportunities. And I know that we're very excited to be getting this this next step. And thank you to our Northamptonshire charity for supporting patients. You'll see in the report again, you know, that does mean a lot to people, and for those that have to be in hospital at that time, we know that that does get value. So thank you to them from all of us. We also had a visit recently from Chris Hobson, who's the Chief Strategy Officer at NHS England. So he chose to come and have a look at Northamptonshire, and I'm pleased to say that Anne was able to host Chris, and he was able to have a look and discuss with some of our mental health services, and in particular the crisis telephone support that's provided with Mind. So great for him to understand more about that. Great for him to get a chance to have a look at the mental health crisis. But so we seize the opportunity. I think, you know, great that staff responded well to that. And I know from what Anne said that he took a lot of learning from that, which was good to have as well. Yes, just to mention the Together Against Racism, I echo what everybody said. I think it was a great event. I'd also say we've got a leaflet, a booklet, which describes our journey, because it's been a multi-year journey. It's not just a new initiative. Important to just remind people. We made a commitment to be an anti-racist organisation across NHFT and the group. We remain on that journey, and it is going to be a journey that continues. The programme is, as Chris said, and others, much more now about absolutely getting it embedded to be everybody's business, which is the next critical stage for us. But really, really pleased with the work that's going on there. Having said that, we have more to do. I don't want anybody to feel that we've got this sorted. We haven't, and we still get, as we know, individual stories, but people do speak up, and I'm very encouraged by that, because they know we want to do something about it, which is encouraging. And I was also pleased that colleagues from University Hospitals Northamptonshire are also able to join us on that session. So immediately we can anticipate that spread and learning into University Hospitals Northamptonshire, and obviously subsequently into UHL, which I think is great, because that's that means that, you know, we're building and learning together in the system as well as across the group. And I will leave it there. Thanks, Krishni.
Yeah, anything anyone wants to question, come in or comment on in Angela's report? Whilst people are thinking about that, I just wanted to really note, I think, as much as anything, there's some really good, you know, initiatives reflected in local initiatives that I was quite excited to see small examples of projects, improvement projects that involve our partners. Pumped Up, the Fitbits. As people might know, I'm a great advocate of trackers and how they can be, because they are incredible for the amount of data that they can provide, and the motivation, if done properly, they can. So, you know, the idea that, you know, Fitbits, the issuing of Fitbits, and I actually went into the link to read more about that project, because I thought that sounded really exciting. The Pumped Up support group, the pilot lung screening program, you know, these are, I think, really important things to highlight, because they're all improvement initiatives and reflect a different, you know, both health initiatives, but also more socially based, you know, prevention type initiatives, which are, you know, very in keeping with where we're all trying to get to, I think. So welcome those. I just wanted to ask whether we had it. I mean, obviously the idea of visiting being a fundamental standard of care seems very appropriate, I think, after the experience of the pandemic, and we all know, you know, how important the role of carers is, and important others for individuals who are experiencing challenges with their own health. Just perhaps too early to say, but are there any likely implications for us from a in terms of any of our services, or is that fairly something that we would expect to be able to accommodate pretty routinely? So it was just something that, you know, I thought was worth pondering on, really.
Yes, I mean, from my perspective, Linda may want to comment because of the COVID era that we're in on visiting, but from my perspective, that is something that we should be able to accommodate. You know, it's something we did accommodate in different ways through COVID anyway, in different ways, or access to carers and relatives. But I think the if you like, the thrust behind this is that there was clearly a lot of effect of COVID on visiting, and particularly for those cultures that could be at risk of developing closed cultures as well. So this is something that, again, you know, I think has come out of the learning. So I think it's to address many things, the importance of carers and family for people's care, and also the closed cultures element. So I think it is something that we would, you know, obviously fully support, Krishna.
Thank you, Angela. Anne?
Sorry, I couldn't click off mute. Just going to say, I think that the lived experience voice is so critical in that the whole closed culture piece. We're really fortunate that we pushed forward with carers workers quite early. They weren't, as peer workers were very much talked about, but carers workers were quite important for us. And one of the things that we were able to maintain virtually through COVID, and then coming back to face has been our carers corner for people who are who have had a loved one on the wards, and the support they can get through that. So I think we've tried to be creative in as many ways as possible, because we always need to think about how we include that lived experience, and often in crisis it's the carer who speaks out and who needs that input in that crisis moments, and I think that can hold so much information and knowledge for us, but also a great deal of trauma for them of going through those experiences. So how we sensitively work with carers is important, and I think that worked quite well online through COVID. Not as we'd want it to be, but yeah, important to have.
Yeah, thank you, Anne. Melanie, please.
Thank you. Yeah, a different topic altogether, actually, and I was really just to ask, I've got my wellbeing guardian hat on again, you'll be pleased to know. I was just looking at the remobilisation of the R&R days, the R&R programme for this coming year. And absolutely understand, and we have seen over the last couple of years the real impact that this can have. So it occurs to me, Chris, that probably the Wellbeing Steering Group should track the uptake of these. And maybe add it to our dashboard in terms of percentage of teams who've completed the use of this opportunity, because we know how busy everyone is. We know how staff are sometimes inclined to put their own well-being at risk for the sake of patients. So I think the ability to track it would be a very sensible approach.
Thank you, Melanie. I'll leave Chris. I don't know if you want to come in or.
No, yeah, we can pick that up. I think sensible suggestion.
Yeah, great. Thank you, Melanie. Jo, please.
Thank you. Just to note, Melanie, I agree 100%. I think that's an excellent idea. So like you, Krishni, I leapt into the detail about Fitbits because I also am a great advocate of them. The other thing that jumped out for me was the CQC advice around health inequalities. And, you know, I don't expect details at this stage, Angela and Dave, but it would be really good at some point to understand how our ICS and particularly our Director of Public Health across the two areas are connecting with this type of approach, because, you know, Northamptonshire has a lot of inequalities, and there is a gradient between poverty and affluence and health and wellness. And, you know, this is a really timely reminder for us as a system to understand that we have to accept our responsibilities around inequality. So it would be good at some point to get some feedback on that. Thank you.
Thank you, Dave.
Thanks, Krishna, and thanks, John. We are standing up our internal population health inequalities board imminently. We've got quite a bit of data now that I think will guide us in the work. Interestingly, at the Health and Wellbeing Board for West, we had a presentation from the ICB about inequalities across elective pathways. And it does seem to be fairly even in terms of elective access. And it is a matter of public record, so I don't mind sharing that one of the GPs in the locality in the south mentioned that currently their referrals to the private sector is up at 20%. So that gives you an illustration of an emerging kind of inequality for those who can pay and those who can't, and what are the implications for that. So yeah, fascinating area. We're really, I mean, as Andrew will confirm and the rest of the team, this is one of the most important areas of our work looking into next year. We want to be front and center leading some of this nationally. There's great work happening in the collab with a prevention pillar. And as you mentioned, Krishni, that kind of left shift stuff is kind of happening with Fitbits and people thinking longitudinally about how do we get ahead of the needs of our population and do that equitably. So yeah, point well made, and happy to come back ideally in March, maybe April, and give a sense of where we're heading and how we're approaching it. Really happy to do that.
Thank you, Dave. And it reminds me, I think, if I remember correctly, Richard, I think we were thinking it might be useful to have a bit of a conversation about health inequalities at one of our development sessions, so we can have that rounder discussion. I mean, appropriate for it to come to board in due course, but is that something I'm trying to think whether we've done that already? I don't recall that we have, so it's probably something we need to feature in. So Dave, we can have that bigger conversation and really get everybody up to speed with how things are developing, both in the system with our partners and then internally as well. Does that sound like a good opportunity?
Yeah, great. Really welcome that, Christian, and also a really great opportunity in the group, as you know, because the populations are different, as you say, Joanne. You know, there's inequality deprivation here, but actually, in terms of certainly the racial ethnicity profile in Leicester is fascinating, and what can we learn from that? So yeah, big opportunities.
Thanks, Richard. Thanks, Dave. But Richard, I think we've got it on our list, haven't we, of topics we want to come back to.
We have indeed, yes.
Great. Okay. Julia, please.
Thanks, Krishni. Just building on that same last point, we held a really useful workshop from the Quality and Safety Committee last year, and one of the focus was health inequalities and our populations through a quality and safety lens. And some of that work I know is feeding into some of the group, etc., that Dave's talking about now. So we're trying to look at it from all angles, I think, to take forward that important piece of work. Thanks.
Thank you, Julia. Okay, so I think that brings us to what would have been our annual update from Jonathan McGee, but as I've already explained, unfortunately, we've had to stand that down for reasons I've touched on already. So we will reschedule that. And therefore, the next item on our agenda is actually a break. So I think it's probably fair to take that break a little bit earlier, and then we can start on the integrated performance section. So we move on to the integrated performance section of our agenda, which is section 11. So first of all, I want to bring Judith in to talk about the Performance Committee Assurance Report. Please, Judith.
Thank you, Krishni. I will take the AAA report as read from the Performance Committee in January. It was a very uneventful and very vanilla Performance Committee, so not very much to talk about. One of the things that I'd like to highlight is a requirement to approve the terms of reference for the committee, where we have reflected the change to our board assurance framework away from a risk register, and the necessary amendments are actually highlighted in redlined in the terms of reference, and that's the only change to ensure our governance is up to date. There are no issues to alert. The two issues that I would like to advise the board on is static from last reporting period. The first one being the system annual planning for the next financial year, the continued ambiguity on prioritisation, rising costs, the deadline, which I believe, and this may have been overridden since, but certainly at the time of the committee, The deadline for submission remained the same. This all meant that the Performance Committee felt that it was best to escalate and advise the board of this to the extent that this is not already known. The second item was relating to finance update that requires an advice. The continued stress on the Trust's financial position through the winter, continuing strikes, the ongoing challenges around delivering the break-even plan really all mean that the committee felt that this was an advised item. However, there was a discussion around a recent change by NHFT on treating of lease costs, which that there've been a change in rules, which means that capital the part of our capital plan now has to be treated as part of the expenditure. Although that this is likely to lead to a 1.5 million increase, NHFT has taken a decision that this would not impact, the bottom line, as it were. We would carry on with the capital expenditure because it was felt that the work that was being funded, for instance, the anti-ligature work in some of our wards, is needed to continue to ensure safety of our service users. And this type of decisioning at a time of immense financial pressure was very much positively recognised by the committee. The items that we received assurance over broadly was the integrated organisational report, which is shortly to be presented to the board. There was a number of discussions around IAP services and improvement of access, and also our adult ADHD waiting lists, which continue to be high. And the committee was also cited on our internal into the TIAA assurance report on performance management, and also the action plan that has come off from that. We also received assurance from the board assurance framework, which has been static, and the committee welcomed the having visuals over the corporate risk register at the next meeting. And finally, the digital transformation update, which is certainly from my point of view, very, very interesting. I've experienced a number of digital transformations in different organisations. And this is a very positive programme, both the 23-24 plan, but also the external What Good Looks Like programme are on track and delivering very positive results. The Northamptonshire Care Record is up and running and has a very good take up by all parties concerned, so that the patient service users' care records are now amalgamated into one system and are accessible. The one thing that the committee noticed, or rather two things the committee noted, is the ongoing continuous work that is required to ensure that as an organisation we remain cyber security resilient. And from a data point of view, that we ensure and continue to work on the data being complete, accurate and timely within our systems. And from a staffing point of view, that we continue to offer training to our staff, which there is, the committee received assurance there is a plan to do. That is all I would want to highlight from the Performance Committee, but I'm very happy to take any questions. Thank you.
Thank you, Judith. Any comments or questions on that, Saki?
Thanks for the update, Judith. Obviously, is there, but just a phraseology suggestion on the bottom of page 70, where it says revised forecast outturn of 4.8 deficit has now been agreed with the ICS and HSE. We remain on track to deliver this at the end of December 23. I was wondering whether I should say at the end of March 24 as forecasted in December. Perhaps that's what I was trying to say.
Yeah, absolutely. Thanks, Akib. Thank you.
Okay, is that I haven't, but I can't pick up where it is actually, because the numbering on my papers might be different. So are we clear where that is? That it's just a note really to make sure that we pick that up correctly in terms of interpretation. Richard, Louise, Jane, are you comfortable? Okay, great, thank you. Is there anybody else wanting to come in? Paul, please.
Thank you, Krishni. Yeah, it was just a couple of extensions to what you had set out as far as the advice were concerned around annual planning process, and as the paper articulates, we're still waiting for the operating guidance to be able to sort of firm up any of that. I had an update from the national team in the middle of this week, which wasn't really much of an update to what we've got, but I think one thing that is helpful is the fact that the submission was likely to be the end of February. That is recognised that won't be now the case and will be moved back accordingly. But until the discussions with NHS England, the departments and government are concluded and we all get that operating framework, I think it's really difficult to say when submissions, both draft and final, will be required. So I think that is a bit of a watching brief, and we'll need to navigate our way through February, March as far as that is concerned. And I just wanted to comment as far as the capital side of things was concerned. It's really unclear about where the national position is on the treatment of leases in year, given that guidance is changing within the financial year, and we had planned that those costs would not be part of our capital expenditure. My standpoint to date has been that we won't compromise safety as a trust, and that where we can manage our expenditure down, we will do so, but that won't be at the expense of patient or staff health and safety. So that's the position I've given thus far. I think there is some road to run as far as this is concerned, both as a system, a region and a national position. So again, I will keep everybody apprised if and when more becomes available or not.
Thank you, Paul. Chris, please.
Thanks, Krishna. Yeah, just a slight admin correction, because we went through the titles of the joint posts. So the Group Chief Digital Information Officer should actually be the joint, not the group, because only certain people carry the group director role, such as David and Paul.
Okay. Again, I don't know whether I'm sort of looking at the wrong thing here, but where is that, Chris?
It's in the membership of the TOR.
Oh, okay. Yeah, fine. Yeah, thank you. So we need to make those changes, which are noted. And can we approve it subject to those changes being amended and submitted back to the Performance Committee? Is that okay? Great. So we'll approve the changes to terms of reference, but we'll note the title comments that Chris has made. And thank you very much for the update and subsequent comments from other colleagues. We move on to the integrated organisational report. Over to Dave, please.
Thanks, Krishni, and I'll join colleagues as we go through this just to kind of top and tail it. So just a bit of context. I mean, as Angela and Krishni have said, just to echo the thanks to teams where it is ambiguous times with planning guidance pending, and obviously the ongoing recovery from COVID continues along with winter, as Anne said. So the earnestness and the diligence within which teams approach this work and continue to kind of develop the organisational report is commendable. So warmest thanks to them as ever. Other bit of context, we had at the Health and Wellbeing Board for West the first of the COVID impact assessments from the public health teams. And as I've said before, I do think the COVID inquiry is going to kind of shape some of how we approach healthcare delivery for a long time. And I think we're seeing the start of that becoming true. So some of the headlines for that were significant, so a sample group of about 7,000 people, cross-sectional across the West North Hants. Mental health almost a 50% increase in general population, which of course we're seeing within services across our range of services. Similarly, musculoskeletal issues within the general population, compounded by working from home, sedentary kind of lifestyles. As those of us that worked during COVID in the NHS, I mean, those were 14, 15, 16-hour days sitting, staring at a screen, and that's going to have a longitudinal impact. And we're seeing that in the demand for services. So I think that's quite important as we go through some of this, particularly in relation to children's services too, who really did suffer during that COVID period. And again, we're seeing the output of that now across waiting lists. The other context is, as Paul said, planning. We are expecting to, in the plan guidance, to increase our integrated response times from currently we operate till 1 a.m. in the morning. We're expecting that to go to 24 hours. That's our 2-hour response, which we're doing really well on. Probably best in class, actually, in terms of meeting 2-hour responses and pulling patients off ambulance stacks, etc. So that's a really powerful part of our UEC contribution to the system, and a reminder that it's not just pressures in acute services. We see those pressures in our own services too, and we make a contribution to it, which is really important. So just those kind of 3 bits of context, I think. Just into the report then, I mean, I think you and I were discussing that we probably have reached peak data with some of the reports, and we'll have a look at what we do in terms of the breadth of material that we send to the board and the breadth of material that we consider at the performance committee, and can we differentiate between those two to make it a bit easier to digest, bearing in mind that this is a meeting in public, so for our populations, probably useful for them to see something a bit more digestible. So we'll do some work on that, but again, great to have the breadth of information that we've got now that kind of informs the work that we do. Into some of the headlines from the cover sheet particularly, and then we can go through the report through questions. We are seeing now an improvement with people accessing our services within 18 weeks for treatment. So we've moved up from 91% at the last report to 93%, and hopefully we'll sustain that. That's a pretty important metric for us in terms of quality of access. In terms of our referral to treatment services, these are our statutory consultant-led services. The report in December does illustrate continued delays within our community paediatric services related to services provided in NGH. There is actually an improvement in January of this year in those services, which is promising, and that links to our CYP, particularly ADHD and ASD access. So important just to bear that in mind, that we're seeing some movement on that at this point. I'll defer to Chris in a moment just to cover off some of the workforce issues, but as you said earlier, with the Integrated Assurance Committee, we do have a really robust structure now in place for looking at our workforce activity, and we've done quite a lot of reinvention of some of the work within the staff bank, and communicating particularly a transition from using agency to different approaches, and that's going to be really fundamental to how we approach 24-25 to try and crack that. Other headlines in terms of areas of concern, I guess CYP, ADHD and ASD pathways remain a concern across the system and nationally. That was confirmed, as I said, by the Health and Wellbeing Board Public Health Committee. The team have done a really great work on safer waiting, which is a 4-year reflection on how they've approached the spikes in demand that we've seen in children's services. And I know Health Watch equally will be taking a look at CYP pathways more generally across the county as part of their mandate. And indeed, the local authorities and public health are looking at from statutory individual organisations, those two unitaries, how do they want to shape those services going into 25-26, and we expect to, well, we would be part of that discussion, but it will involve change inevitably about how we can configure those services and indeed how they're commissioned. There is now also a national task and finish group specifically looking at ADHD. It's got an expert reference group. We're feeding into it as a trust. Paul Flecknoe, who's our chief psychologist, is involved in that. And we've got ongoing work with Ofsted and SEND inspection. It concludes today, which is looking at children's services, and that is bringing up again the same issues that we've flagged as a trust, and indeed is reflected in the quality and safety report, the assurance document, in terms of those concerns about weights and the grip that we have on that. And I feel reassured that we do have a grip on the underlying issues, and the teams are managing the safeguarding risks as best as they can within the constraints of the resources that we've got, and that's part of the ongoing system discussions in that space. In terms of MSK, as I said, the public health picture on this remains tricky nationally, and undoubtedly the planning guidance will contain detail about what role the NHS is playing in keeping people in work and getting them back to work. We see that within our own workforce, but equally we have a really important part to play in the general society's approach to economic activity. We have got 9 staff starting in February, in our 8-point-odd staff starting in February. We think that will have quite a material impact on those waiting lists in MSK services, and we're seeing that across some of the other areas that we've got issues in terms of weights. Finally, then, on system performance, we've got the QRSM on Friday, as Angela said, that will obviously focus on finances and system performance, particularly UEC. The challenge for us is making sure that the voice is heard around getting ahead of urgent and emergency care. How do we get downstream to prevent those needs? And we have a really key role to play in that as a distributed organisation across Northamptonshire. Talking therapies and SMI health checks are likely to feature as well. We're on track to improve those. The SMI health checks, obviously a system metric, but really plays into the inequalities conversation, and we are seeing a straight line, almost straight line improvement. It did dip a bit in December, but we are tracking up on that with Angela leading through the collaboration. Dementia diagnosis, great story from the opening plenary, so we're on track in improving that, and a great example, as people have said, of a quality improvement initiative. And the ICT 2-hour response, as I said, will be shifting that, probably not in 24-25, but certainly into 25-26, into a 24-hour service, with, again, making a material contribution to urgent and emergency care as a partner within the system. So, to draw breath, Christian, can I just draw Chris in, maybe just to talk about the workforce position, and then Paul, if there's anything you wanted to top off on the finances, and indeed Anne, from an operational perspective, that'd be welcomed. Thank you, Chris.
Yeah, thanks, Dave. So just running through the headlines, vacancy position still positive. The turnover has increased, and turnover is an area of focus. We did, I think, discuss that at the IAC, and for the new recruitment and retention group, we're going to be we've established to look at this, and I think we can do a more detailed analysis at the IAC. We do look at the reasons for leavers in our workforce planning group. That's an important area. We've also described that the calculation slightly changed, which increases it, and also the financial position makes it a challenge, because turnover is a factor of those leaving against those in post, and obviously we're looking to either maintain or reduce the numbers in post, so that will impact. But as I say, an important area. Sickness is really the challenge of COVID and flu, which remains. Mandatory training has dropped with the Oliver McGowan training, which is a real area of focus within the organisation, to how we address that. When we're introducing a new mandatory training, this often happens as we've got to pull everybody back up to meet that new standard. So I know from Anne's team, the ops team, and our L&D team, working really hard to make sure that this standard goes back up and we meet it. And appraisal compliance remains an area of focus, particularly in the corporate areas. Those are main headlines on the overview figures. On the agency, and we shared detail in the Integrated Assurance Committee, there is an awful lot of grip on that. The main areas that are causing us challenge are prisons, in particular Peterborough, and medical agency, although Itai has just returned from a recruitment trip to India, which hopefully will bear real fruit in managing the medical element. We've got deep dives with Peterborough to look at what's happening. By contrast, in our mental health areas, the teams are working really well in reducing agency. A headline is we've agreed with 5 members of the agency staff to come over to our bank, which clearly we'll run through. So that continues to be a key areas for us to focus on to ensure that we can grip the agency. And we discussed at the workforce planning group, as Dave will say, we do think we can meet some new targets next year that can feed into the savings and the overall plan. Happy to take any questions.
Thank you, Chris. Angela, do you want to come in?
Yeah, it's just in relation to that the turnover position, which Chris has said, you know, increase, but obviously in the notes it talks about the exclusions, which is important. And I'm just wondering, Chris, you know, things like junior doctors, it's, you know, planned turnover, if you like. It's not turnover in the sense of staff leaving the organisation, as in retirement as well. And I just wonder whether we are confident that including all of that in our dashboard, which is the overall figure, the comparisons being made against us and other trusts the same, because that just makes me feel that actually that's not our turnover figure, which again is added in the notes, but in our dashboard it's the obviously the original figure. So it's just that confidence about comparability, really.
Yeah, we have been through that in the past. People take different approach. I mean, I think you make a good point, and I think as we move forward, it might be better for us just to show both figures so people can see it. Because I know non-execs are keen to have that assurance of the overall position, which I think is right. But I think that might be helpful, Angela. And as we look into the reasons, quite, you know, substantial numbers do, as you say, the percentages do leave for retirement, they do leave for promotion, they, you know. So a chunk of the turnover for positive reasons. So we, you know, we wouldn't, you know, we're not going to have a strategy to actively persuade people not to get promoted. So yeah, I think as we've had the discussions in the ISA, a bit more, the 2 figures might help, and through Dave's review, and actually being able to share more detail of what's behind it. Again, because a lot of the turnover, a chunk of turnover, so a sizable chunk, maybe 2 or 3%, is planned turnover anyway through junior doctors and others.
Well, that's the bit. I think the junior doctors bit one bothers me the most, really, because actually that is, you know, part of their, you know, rhythm of working, and not really turnover for me.
No, I'm happy to, yeah, we have looked at it before, but happy to take that away, because as we say, it's a hot topic of discussion, both at an exec and operational level, when we're looking at in the new workforce planning group that is really bearing real fruit, which Dave can maybe comment on as well, and then into the strategic workforce group and back to the integrated assurance. So happy to take all that away and work it through.
Thank you. And that does sound sensible, really, particularly the junior doctors element, which is, as you say, it's sort of planned, isn't it? Anticipated. It's not, you're not expecting people to stay. So, and we do need to be comparing as far as we can, apples with apples, I guess. I just wanted to maybe bring Paul in a moment, but Sakib, I think your comment actually I've now spotted, I think it's the bottom of this report, financial performance at month 9. So at the bottom of the covering report for the integration organisation report. So can you clarify what that was, and then I can bring Paul in just to comment on it, because it was, we remain on track to deliver this at end December 23, and you were querying that, weren't you? Is that right?
Yeah. So as in, you can read it in different ways. So we're on track as at the end of December to deliver it at the end of March, because otherwise it looks as if we're implying our calendar year, sorry, our financial year ends in December. Obviously, lots of commercial organisations do, but obviously in the NHS we're in March. So it was just to clarify that somebody didn't misunderstand when our financial year ended.
Okay, thank you. So Paul, I think it was just to clarify whether we ought to be clear on there that we're on track to deliver this for the financial year, or just at the moment in the month, I guess is the point.
Yeah, indeed, Krishni and Sakib summed it up really well. We'll tighten the wording up for next time out, but just to be absolutely crystal clear, we're still on target for the end of March delivery of the position, notwithstanding the treatment of strike costs as we go forward. Board members will remember that we've incurred strike costs throughout this financial year, but they were effectively bought out by national monies in November. But obviously that was on the assumption that there'd be no more strikes, and we have incurred those costs. So that 4.8 million may change because of that reason, but we are, as a key points out, we're on target to do that by the end of March based on the end of December's figures. And the point I was just going to make was we still continue to make good progress, Krishni, as far as the value programme as savings are concerned. So we're just behind at month 9, but we are confident that we'll still be there by the end of March.
Great, thank you, Paul. Couple of just brief comments really, and one from me. One was, I suppose in the overall context, Dave, of your comment almost at the beginning about sort of data. I mean, it would be probably, it's quite helpful, isn't it, to perhaps just think about from April onwards, what you know, is there anything we want to just reprioritise onto our board, you know, in terms of exception reporting to the board? So I think it's a good time to do that. So I really just wanted to support that and check with you. I don't know whether I've heard this incorrectly somewhere else, but I thought I heard that there was going to be some kind of change to the IAPT target. Is that, have I misread that somewhere? But I was led to believe by somebody that there might be a change in terms of the way it's focused on access. So I don't know whether you picked that up anywhere, Dave, or whether that might be in guidance to come.
Well, there will be some for sure in guidance to come, but maybe could I pull Anne in, because obviously the prevalence changed, but Anne will have the contemporary feelers out with that.
Yeah, they are looking at changing how it's recorded, and there's a lot of work that happens in IAPT that it's very process driven about how you work through to access. There's a lot of work that happens at the front that can be very supportive, that leads on to maybe referral to other, you know, other third sector organisations or other activities that may not always be counted as access. We don't know whether the changes that they're considering, it's only just come through, will make a difference to what we're counting as access. We need to work through the detail with that, but they are making some changes about how we calculate that access target, and we'll report back once we know the impacts of that and what it will mean.
Yeah, thanks, Anne. That's helpful. And more, couple of other brief points from me, and I can see other colleagues want to come in. Just wanted to remind all of us that actually Oliver McGovern training has been added to all of our expected training, mandatory training requirements. So we all, in order to help us collectively achieve our target, we will all need to complete our training if we haven't already done so, because I think that just happened, and I could see that in our very own compliance report. So worth mentioning. And the other point actually was just really regarding IQVIA. I haven't quite learned the way of pronouncing that yet. IQVIA. I think that was what other colleagues said. Equivoca. Right. Okay. So one of the conversations we had amongst the NED group was actually just about providing some assurance to our councillor governors around patient experience and actually, so that might be a topic that we cover with them at our next council. So I just wanted to highlight that. And obviously this is quite a big change because we had, you know, I Want Great Care for such a long time. And one of the things I was just interested in, not necessarily for now, but I'd like to understand whether we had a trajectory for what our response rates were going to be, or whether there's any guidance from them about what you would expect. So what I don't know is whether 394 responses is below what you would expect at this stage in our implementation or better than. And I think it would be quite interesting. It's the sort of question that our governors might want to ask. So I don't know if we have any insight to that, but I think it might be helpful to just have a sense of what we were expecting and whether we're meeting our expectations. So Dave, are you able to comment on that at all?
If I may, I'll draw Linda in, please, Krishna. Just on the Equivoca, I mean, I know there's probably a contractual reason, but we have certainly mooted moving into something that's a bit more patient accessible. It doesn't exactly say what it is on the tin, so we will continue to explore that to try and have something a bit more accessible for patients. But Linda, could I just draw you in on that comment from Krishni, please?
Yeah, I'll come in on that, Krishni, and then we'll be able to advise board on that. But I just wanted to share that when we moved across from I Want Great Care to Equivia, we did have some of our services that were not using the feedback. So actually we've increased the services that are using that. But I take that point that we just need to understand whether this is what we're expecting at this stage or not. So I can take that back, but actually where we are now, we've got more teams actually using the feedback service, whereas previously we had less teams. And as David said, we're trying to make it more accessible. So it's not just paper. We're doing this paperless as well, and then rolling out now to try and introduce the text messaging. That will be done in a phased way and not all the teams at once, because we want to learn what we can adapt as we go along.
Great, thank you, Linda. And as I say, I think it would be a really helpful, we might not be able to give a really full picture of it, but I think the fact that we're using a new system and we're making it available and to more services to use it, I think is all helpful to share with governors. So that's perhaps a focus for our next assurance topic for Council, and Richard and I had discussed that earlier, previously anyway. Okay, thank you. Judith.
Thanks, Krishni. I just wanted to reflect that not only are we seeing a real journey and a lot of assurance that both the board but also the individual committees are receiving from the BAF, but now also this integrated organizational report. And I really welcome that. It's really easy to triangulate data. I really welcome the addition of the financial ratios, which is something that I asked for and a number of other people asked for, and it's now included. So thank you very much, and really welcome all the changes, and thank you for the teams too.
Thank you, Judith. Scott, please.
Yeah, thank you, Krishni. I mean, I think it's similar ground, to be honest with you. So, Dave, I mean, I think it's an important reflection that you've brought forward, and you've kind of prompted this aspect of debate. But I wanted to make sure I was sort of supporting it in the right way. The integrated organisational report has become entirely core and intrinsic to the committees and the board that receive it, and it's a fantastic piece of work. It genuinely is. I don't know if I can use myself as something of a bit of a proxy here, Dave, right? But when I get to it in the committee materials, I almost give myself a little pep talk to redouble my concentration and my focus to make sure I'm absolutely zoned in. And I think that plays to the point that you were making earlier on, right? So in becoming such an intrinsically important read, it's not necessarily an easy read. And if I was to augment what I was originally going to say with Krishni's comment as well, I think you were talking about is there room for a more digestible format, perhaps, inappropriate for it? I think probably yes. And I think Krishni's prompt around sort of moving in an appropriate time frame to seeing a window on it here or a lens on it here where it's in a more exception reporting level would be absolutely pertinent. I just didn't want any of that to deflect from the fact that in my opinion it's the best set of reporting of its kind that I've seen, and there's a danger that it almost becomes a victim of its own success here, Dave. It's so good that we almost need to think about how we throttle back in some areas. So I hope that makes sense.
You know what, I really appreciate that feedback, Scott, and the team will really appreciate it. So I really value you saying that, and yeah, just thank you. I think we're all speaking the same language in terms of peak information and what we do with it next. Yeah.
Thanks, Dave. Thanks, Scott. Julia, and then finally Angela.
Thanks, Krishni. For me, one of the most important benefits of this, and we've watched this report really mature over the last few months, is that all the information's in one place, and you can't underestimate that. The committees used to see different bits of information and review things not so much in silos, but slightly from different lenses. I think this brings together all that information in one place. A couple of quick examples of how we've had different conversations. like you just suggested, Krishni, around the IQVIA system, we'd already had in October at the Quality and Safety Committee an update, a full presentation and a chance to question on many aspects of it. And I think then it comes here, it then goes to Performance Committee. So I think people are looking at it from different perspectives and bringing that together. So really, really helpful. And certainly we welcome, you know, sharing with governors our journey so far and the assurance we've been able to take in the different committees. And just to say that, as another example, in the safety section, patient safety incidents, pressure ulcers remain high numbers of those patient safety incidents. It's viewed through Performance Committee, viewed through Quality Committee, and we will be having a focus on that in the next couple of months at Quality and Safety. But the richness of the conversation at the Performance Committee helped towards that decision to review that at Quality and Safety. And lastly, the ADHD services, as you mentioned, Dave, earlier, again, the information is here, but we absolutely, through the report that we'll do in a minute from QNS, had a deep dive and a focus on that for the children's services. And it's all stimulated from a lot of it from this report, bringing it all together, looking from different lenses, and really think that's made quite a difference into how we view and the questions we ask. So thanks.
Thank you, Julia. Thank you. Angela, finally.
Yeah, no, definitely echoes everybody's comments around this report. I think it's very, very helpful, and it's in a great place. But just want to signal that we need to do more development work as a trust and across the group around productivity. And I think this is something as part of a national discussion yesterday, and I think that might be developmental opportunity across the group, Krishni, because we know that that's something that we want to and should be increasingly focused on. It's less developed in the mental health and community sector. So I think, again, as a group, I think we'd want to be, if you like, pioneering some of that work and looking at it. Paul, obviously, in his group finance role, is obviously also, you know, very much involved in trying to make sure this is part of the value programmes. But I think it's a developmental piece for the boards that we need to come back to.
Yeah, really, it's a really good point, Angela. I mean, the conversation about productivity is not going to go away. I mean, I think it's part and parcel of where we are as in the NHS at the moment. So I think it's going to be really important that we have and I think, Paul, in a development session, I think, Paul, you shared some thoughts, didn't you, about how that was developing from a mental health perspective. And even if there are some, I don't know, early things that help us to kind of, I'm always in favour of proxies that might be helpful as a starter for 10, that as long as they're used in the right way. Because I do think those sorts of things can, you know, the importance of these measures is Julia's point about, is it driving the right conversation and the right focus? I mean, ultimately, all these documents and these, you know, things that we look at are all about, you know, does it tell us a story about where we are and what we can do better? And so anything that helps us on the productivity front, I think would be great. So we'll come back to that, no doubt. Thank you. Melanie, did you want to come in for a brief comment?
Well, just to find out, I absolutely agree, Angela, and I'm assuming that you kind of mentioned this in the context of productivity should feature in the organisational report at some point. And whilst recognising my colleagues' desire to see this simplified, although I must say I think the trust level section is actually really digestible as it stands. Yes, if you want to get down into the rest of the detail, it becomes a little bit more complex, but the trust level, I think, is well placed. But the only other thing that I would encourage us to think about, maybe at some point going forward in this organisational report, maybe to replace some of the content which might be more stable, would be, can we reflect in this report at any point something that's relevant to health inequalities and how we're tackling them, and also our social value achievements, because having launched the charter, it would be good to see that front and centre of some of our reporting as well. So, you know, just to add to the list of complexity, Dave, that you're going to try and simplify, I think those two areas would also be very valuable.
Thanks, Melanie. And I think we'd all support that, because we've said we need some way of measuring our impact on that. And, you know, we can't sign a charter and then not have the evidence to back that up in terms of taking it forward. So I would absolutely support that. Final comment on that or anything else, Dave?
Just a really helpful discussion, and I mean, as ever, ongoing work to do. If you recall, the internal audit did mention when it reviewed this report that the missing segment was the fourth stool, the fourth leg of the stool, which was strategy and partnerships, which picks up the social value inequalities bit. So that's in hand and we're working it through, but good observation. Thanks, Melanie. And thanks for the feedback. As I say, the team will really appreciate that. So keep it coming. Thank you.
Thank you. Thank you, Dave. So we are really noting the report. We've reviewed, obviously, some aspects of our performance and areas of risk, and sought assurance where appropriate. So thank you. We move on then to our quality section. And as Julia referenced, the first of those reports is our AAA from Quality and Safety. Please, Julia.
Thanks, Krishni. So we'll take the report as read. No areas to alert this time. A couple of areas on the advised section of ongoing monitoring, which we've described. First areas monitored in quite detail by the Quality Forum, and we're just raising that we're taking assurance from that Quality Forum, but actually we're continuing to monitor some of those areas. And the second point around the board assurance framework risks around quality and safety, and note that subsequent actions after the committee review of BAF 8, which is the risk around delivering high quality care, I think has been reviewed now, and we have the review of the quality framework coming up, and all that will help strengthen the controls around those two risks. Out of the assure section, I must just mention a couple of things. One, we've already mentioned, the first one around the very detailed session we had looking at the current situation and future plans for the children and young people's ADHD service, and that just strengthens everything Dave said around waiting list management, etc. And notwithstanding the impact of a long waiting list for children and families, we took very strong positive assurance from the mitigating actions in place and the plans for the service looking forward. So that was really, really positive. And just to say that in the February meeting, we'll be looking at the adult service, and Dave's already mentioned some actions around those. And then just a couple of last things, if you don't mind me just highlighting a couple more. One was the incredibly positive scrutiny externally from our emergency preparedness, resilience and response submission this year, an annual submission. The reason I'm raising it is there's a huge amount of work goes on in the background by various teams to get this assured, and it's a really important part of our assurance that we are ready for emergencies that come up, and we've already heard in some of the environmental analysis some of the emergency situations that we face. So really important piece of work, and thanks to everybody involved in that. And lastly, in this section, I just wanted to draw out that we had various financial elements highlighted through a number of items on the agenda, and really important that we took the opportunity to question and gain assurance on the maintenance of safe quality services through all those different discussions. And there's a couple of examples there of those conversations. And then lastly, the celebrating outstanding. We always have a number of areas of outstanding practice, but definitely wanted to mention the electronic prescribing and medicines administration system, the EPMA. Again, another very lengthy piece of work, rolled out an electronic system to the majority of our services, and the positive impact on patient safety and the examples of that were just too numerous to mention, and we wanted to thank everybody involved in that, but also the learning that it's worth waiting for a report. It's taken a while, but actually the benefit of taking time and actually highlighting and fully getting the benefits highlighted was really important. So happy to take any questions on that.
Thank you, Julia. Any questions or comments around anything in that report? Just really my observation, I felt, you know, reading the report, I felt it the assurance section was really clear about what assurance was provided and what had been done to gain that assurance. I thought that was really helpful. So I just wanted to say that really, because that reflects the good work the committee's been doing. So thank you to members of the committee and Julia as chair. So thank you. Good. Right, let's move on then to a couple of reports that Linda will be leading us through. So first of all, the Patient Safety and Learning Assurance Report from November and December, Linda.
Thank you, Krishni. I will take it that the paper has been read by colleagues. Just to also mention that prior to us coming to Trust Board, this paper was presented and reviewed in the Patient Safety Committee meeting. A few highlights that I can share, which I included within the report. We previously reported on this backlog of pressure ulcer audits. So I'm pleased to confirm that the backlog has been cleared. We are tracking and reviewing pressure ulcers in a more timely manner, and we've got a working group, which I chair, that is looking at our pressure ulcers with a focus on the prevention and management of pressure ulcers. The next item that I just wanted to highlight was just to mention all the work that has happened with regards to our electronic prescribing and medications administration system, or EPMA, and Julia has mentioned the benefits that have been highlighted. But what I wanted to mention in particular is that we've not observed an increase in medication incidents since the rollout. So that really is a positive insofar as patient safety. I also wanted to just highlight to board all the work that has been done around falls, and we've reported that within this paper. Then moving forward, we've reported on deaths, and this is very key for us, our learning from deaths. Note within the paper that we've not had any deaths that have been attributable, that have been classed as being avoidable. So that remains a strength and positive, and that we are learning from these. We've not had any duty of candor breaches, so again a positive. We've provided an update with regards to our serious incident investigations and our concise investigations. You'll note that we do have some that are awaiting allocation, but this is an improved picture from where we were last year. I also wanted to add that prior to coming into this meeting, I did sort of catch up with the head of patient safety to say, where are we? And subsequently, 2 of the serious investigations have been allocated. So we continue to review this. And I met up with Anne earlier in the week, and we discussed the position on this as well. I just wanted to also ask our board to note that we provided a summary of our thematic reviews that have been taking place. And again, there's a lot of learning that comes through from that, including having thematic reviews presented within Patient Safety Committee. So that again gives enough time for us to tease out further information and obtain assurance around our processes. So I will end off by just mentioning that the report will change going forward as we move to the rollout of the patient safety incident response. We have changed our meeting, which previously was internal assurance meeting. So you will see here, it's now known as the Review of Significant Events Learning Forum. So we commenced that. This was 2 weeks ago now, and again, really good engagement, participation from colleagues. We've also got our patient safety partners who have now come into post and are part of working with us as we roll this forward. So you will see some changes in the structure of the report to reflect that. There is no decision that I'm asking Trust Board for, but I'd ask you to note the proposals here, and then to also take assurance that we are working in accordance to what we have set out in order to meet our requirements with regards to patient safety. Thank you, Chair. I'm happy to take any comments or questions.
Thank you, Linda. Really helpful. Thank you. Any questions or comments then? Judith, please.
Thanks, Krishni. Thanks very much, Linda, for the report. It's a really clear report, and I think my questions may be as a result of not attending Q&S anymore as a committee member. But I was just wondering, in relation to the data where we have an increase in incidents like falls and the medication incidents, do we triangulate the data in relation to staff, for instance, what was this, agency staff, bank staff, full-time staff? Do we understand, because that could potentially assist with working out whether, in which areas potentially we may need further training or support? I'll just ask my questions and give you a chance to respond afterwards. I really I was very pleased by seeing the reduction in violent incidents and assaults against staff. The question I do have is, do we understand whether this is partially lack of reporting? I'm really happy to celebrate events, but I just wanted to just ask that question. In relation to medical devices, are we planning to calibrate for different ethnicities going forward? Because that's something that I think I did ask a while ago, and I think there were some plans in the pipeline. And lastly, I got a bit confused with the chart on new pressure ulcers on page 112, and then the all new admission pressure ulcers on page 126. Didn't quite understand the difference. One is on the rise, the admission pressure ulcers are on the rise, whereas the new pressure ulcers are not. So if you could just enlighten me. Thank you very much, Linda.
Linda, do you want to come in on a couple of those now, or do you want to wait and see what other questions pop up and pick them all up in the round? How do you want to play that?
I can do any, Krishna, that's all right.
Okay. Shall I? Sorry, did you say you'd come in now, or?
Yeah, I can respond now.
Yeah,
okay.
Go for it. Thank you.
Okay, thank you very much, Judith, for your questions and observations. Just to start, we do triangulate all incidents. So when we see an increase of reporting, that's actually a positive, because one of the things you learn from is those near misses. So those will also feature quite prominently within our reporting. Incidents are attributable to, say, for example, staffing. So in the Workforce Safeguards Assurance Board, we do log those incidents that have occurred where staffing would have impacted that. So we do triangulate that information. With regards to the reporting low numbers around violence and aggression, and I think you were talking mainly to do with staff, there is a lot of work that's going on around that. This is an area of focus that we are looking at within the Staff Safety and Security Group. And the approach has changed. So we are seeing an increase in the reporting now. We are also seeing this as something that's really being discussed in teams, supporting and encouraging each other to then make sure that the reporting increases. So you will see a different picture with regards to this going forward. With regards to medical devices, there's various things that are happening with regards to calibration. So I will come back to you with regards to that specifically. We'll take it back to the medical devices group, and then that will come through into our patient safety committee, and we'll provide you that update. You've mentioned about the 2 reports for pressure ulcers. So there'll be new pressure ulcers, which is all the pressure ulcers that are classed as new. So this is whether someone has been admitted onto our caseload or not. Then there will be the pressure ulcers on admission, which is where we look at this person has just been admitted into our service. So that will be quite different, because this is what they've had on admission. And then some of those patients are already on the caseload, and then they've developed a pressure ulcer, i.e. they've been in our services and developed. So we need to distinguish between the two. So if someone coming in with that pressure ulcers, we admit them into our services, either into our community beds or whichever area, or coming onto a community caseload. And then the other one will be people that we are already providing a service to, say, community nursing, are going in, and then a pressure ulcer develops. So the two need to be clarified, because there will be those attributable to us because it's happened when we're providing the care, and then there'll be those that they've come in with when they've been receiving care through other services across the county. So we just distinguish those two. And I'm happy to pick up with you outside of the meeting if that helps.
Okay, thank you very much.
Thanks, Linda. That's helpful. Thank you. Julia, I'm going to bring you in last, if that's okay, because you might want to then, because I think you go to patient safety as well. So it might be helpful just to round it off with you as well. So I'll bring Melanie in next.
Oh, I get to queue jump. That's quite yeah, again, a little trip down memory lane. I remember completing service visits end to end along the diabetic and high-risk foot pathway. And it made a huge impression on me because when I was in the high-risk foot service and actually sat in on some clinics, I was so impressed by the approach taken by the clinicians to look at the whole person. They were just dealing with a foot problem, but they recognised everything else that made up how somebody ended up in that position who was diabetic, and it was a tremendous service. So I noted with interest the thematic review section in this report. And maybe this is a matter, Julia, that we might pick up in quality and safety, actually, for a little bit more of a detailed discussion. But I'd be interested on how we are approaching this challenge around resource and both recruitment and retention of this specialist service, and how we are responding to NHS England's challenge to put measures in place to protect our podiatry workforce and future-proof the profession. So not necessarily for discussion now, unless Linda, you want to come back in on it, but maybe for Julia, maybe we could pick that up in the next Q&S.
Thank you, Melanie. And interestingly, I was just going to make a comment. I think, if I remember correctly, there was quite an interesting discussion in an LPT board about retention of podiatry workforce, actually. So it might be helpful to just think about, what are there opportunities to share some learning around retention of this key group, because clearly it's a common challenge, isn't it? And it just happens to be I think a patient story that was presented at the LPT board recently, so might be just quite interesting to reflect on that. And I really just wanted to recognise the amount of work that's going into thematic reviews, which I think are really welcome. I mean, at the end of the day, it's about learning, isn't it, from incidents, and the range of thematic reviews and the kind of clarity about the focus of them, I think, is really helpful, because what that tries to do is, it illustrates for me the process through which we're trying to put a kind of broader quality lens and safety lens for patient incidents. So I just wanted to welcome that, really. Julia, final comment from you?
Yeah, you've probably, along with Melanie, said collectively what I was just about to say about thematic reviews, but the additional assurance is that I do attend that committee with an assurance lens, and the incredibly open and honest committee where we can ask any question, and we do look at some of the details, and I gain a huge amount of assurance from those conversations, not only from jointly with the papers, but the thematic reviews. It's having the time and space to do them, absolutely. And as with the electronic prescribing system, the benefit of waiting, because since I've been an ed, we've been waiting for this review to conclude, and we heard from the expert investigator himself quite a lengthy session in the safety meeting last week, and the value of that, and a lot of the things that you've just talked about, retention, issues for the profession and national perspectives, all came through in that report. So the learning from it is huge, and one of the challenges at the end from myself and others was, how do we share this and how do we get that out? And they've certainly taken some actions away, and they've got things in train, I think, anyway, but just the time to do it properly, and looking at a list on a page doesn't bring it to life, I don't think, for people. So I think, thanks Melanie and Krishni, I think that's really important, that they're not just and the whole new framework for safety reviewing of incidents is based on this, I think, the actual learning rather than just individual incidents. So thanks very much.
Thank you, Julia. So I think there was a sort of bit of an ask there, Julia, about just following up the point, I think particularly about podiatry, wasn't it,
Certainly.
Melanie, to pick that up as part of perhaps a focus at Quality and Safety Committee. Other than that, I think, it's a very comprehensive report, as colleagues have said. and there's some really rich information there, which you know, really gives us assurance around the processes that we're using to understand how we can improve and respond to incidents that occur. So thank you, Linda, for your report. And we note that, so thank you. And then finally in this section, we have the monitoring workforce safeguards paper K. So again, Linda, if I can ask you to just brief highlights, if I may.
Thank you. Thank you very much, Krishni. Apologies to Trust Board. We were supposed to present our establishment reviews in November, so that information has been included. And then I will just mention a few highlights on that. I wanted to just draw Trust Board to the new risks that we have included. So with regards to the first risk on medical cover, medics, as in the junior doctors, and consultant cover for the 136 suite. There are plans in place. This has been discussed in Workforce Safeguards Assurance Board, and also Barrett was able to talk through this quite extensively. So at the moment, we've got arrangements in place whilst they work up the permanent arrangements going forward. So that's being covered by our medics. I just wanted to highlight that the second risk that has been included in this report has been included in error. It's not a risk. What actually happened was it was an issue that was raised through misunderstanding. They thought at the time it was a risk, but it's not. I've since had clarification from the medical director, clinical director, that actually that's not the case. So I'd ask that this is removed from this report by me sending the amended report. I can't see Ty here, but he's happy to explain actually what the process is with regards to that. So Ty can come in and just explain that point.
Yeah, just to clarify that I have checked with the clinical director and with medical staffing, and you know, all the community consultants, including the acting consultants, are Section 12 approved. So that's to give that you know, confirmation and approval.
Thank you, Itai. So we'll note that change. So it is the second, well, it's the community mental health teams. That's what it refers to, doesn't it? Am I right? Yeah. Locum cover without Section 12 approval is the point that was highlighted. So basically, you're assuring us that that's does not need to be recognised as a risk. Thank you. Helpful. Thank you. Anything else you wanted to highlight, Linda? Or,
yeah, just to mention. Yeah, just to mention that earlier Chris covered the issues around mandatory training supervision, so I won't be talking through that. And the last bit I wanted to highlight on our establishment reviews is that when we have completed them, just to provide further assurance, we go through the process of triangulation. So we use the accredited MHOST tool. Then we will then triangulate this with the professional judgment staffing tool. So what we are recommending to Trust Board today is that there are no changes in these establishments. Some of the issues that we had with the data collation that we had is that the process becomes quite limiting due to the number of days. So if they haven't had that full 20 plus days, then the information we get is not as accurate as we'd like it to be. We also noted that for some of these areas, we did have a reduction already. So that now sits with that triangulation of our information. So we are not proposing any changes at this stage. We are restarting the 6-monthly establishment review. So the data collation and everything starts next month. So we will be able to present the outputs of that at Trust Board when we usually report on that. I think it's June that we bring this back to then be able to report. So when we've looked at the reviews that we've completed, the clinical judgment is also taken into account with regards to this. And we note that some of the things that skewed our information, for example, we've got registered nurse associates who previously were not factored in. So when we start to count those numbers, it looks like we need more of the RN, but actually we've got the support of that post. And also that post then also feeds into above our healthcare support workers. So we're just working through that, but certainly not recommending any changes with regards to the reviews that we have completed. And then just ask Trust Board to note the report and information provided. I'm happy to take any comments or questions. Thank you, Chair.
Thank you, Linda. Any further comments or questions regarding any aspect of that? No? Okay, thank you. I think we can just note that then, Linda, in terms of what you've recommended, and particularly that there are no changes. And we've obviously also addressed the issue of the risk that was included, but is recognised as not really accurately reflected there. Okay, we move on to our last section, which is governance and assurance. We have the AAA report from Audit Committee first, please.
Thank you. I'll take our report as read, but I'll highlight some points. And I was trying to recall, was this the one that you attended, Krishni?
I think I was there briefly. I was probably there for an hour or so. I've tried to get round to most of the committees and just spend an hour or so, just as part of my well-led experience. So yes, I was there briefly.
So you're very welcome, and you're welcome to come again. So it was for the time of the year that actually is before audits start and before the budgeting will be happening for the next year. It was still quite a healthy debate, and there were a number of things that were covered. So I'll cover some of the main areas. So on anti-crime, with the cost of living crisis and other issues that have been ongoing, there were still things both in our area and others where we just need to be on the lookout. So whether it's people working in more than one role, an ongoing case that's still being investigated. But that was on the performance management and financial controls, they both had reasonable assurance, so that was good, and there's nothing specific that was brought out. Something that I really want to highlight is the cybersecurity, so that was a good assessment. We had a presentation from Gareth on the cybersecurity, on what we're doing, how we're doing it, and the gaps that we have. And I think it's a collective team effort that we actually are in a very good position. So it was good to hear from him. In terms of some other areas, the things that I wanted to mention were the fact that we reviewed SFIs and scheme of delegation, so some of our routine business that we need to do. But something that came up, because I think it had only been announced that day or a few days earlier, was over the visas situation and the change in the amount that staff had to earn. And it was then actually covered in a subsequent committee. So I guess an example of triangulation between the different committees working together. And we've had assurance from Chris that most the staff that we generally employ aren't affected by those changes. So that was what I wanted to cover. And just something that's happened yesterday, which is post-report, but with our auditors, the partner and the manager are being changed. So they will be replaced and there will be new cover. So whilst it's not ideal, I guess these things happen. They're both being promoted into bigger and better roles. So I guess we wish them well in their new roles and look forward to working with a new team. So it is a very busy time of year. There are reports that will be backing up that haven't yet concluded. And as we move into audit, budget, reforecast, closing the year end, I think it will be a very busy time for finance and everybody else. So I'd thank them for all their efforts.
Thank you, Sakeem. David.
Thank you. Thanks, Sakeem. I just thought this was an opportune moment just to highlight that when we're together for a joint board with LPT in February, we've phased in some cybersecurity training in order to make sure, and we're using the NHS England recommended supplier of the cybersecurity training. So that'll be a really useful bit about both personal responsibility and board responsibility for cybersecurity.
Thank you, David. I do just want to mention that we might have just reviewed the agenda and had to reprioritise a little bit. But I don't know if we've absolutely confirmed the position, but and Richard might want to comment, but I think we were looking at whether we needed to bring our Craig Howarth in to talk about CQC inspection regime, but we haven't finalised yet. So just to say that that's not to say we've deprioritised it. We will absolutely commit to doing that. We just needed to have a look at that because there might be some other pressing issues that we needed to cover. So just wanted to mention that in case we're not in a position to do that training. But I will leave Richard to liaise with you, David, depending on where we've got to and looking at the agenda. Thank you very much. I think it's over to you actually, David, for the group chair's highlight report, and Julia may also want to come in because obviously she's co-chair on this. So David first.
Thank you. Yeah, and Julia and I have spoken. I'll do an introduction and then the bits I missed, Julia will catch back up through. So this is here just as a report because, again, a little bit like Tim's report earlier, it's a timescale issue. We haven't got the AAA report because the meeting was only a few days ago, so we've done a late paper and a quick update. In terms of actions and things, I think a really useful meeting. We've had another look at clinical representation across the group and how that can feed into the joint working group. We did talk about Together Against Racism. I wasn't going to go back through that because we've talked about that today. I think we had a useful conversation around provider collaboratives, capturing the learning that's come from the provider collaboratives and also reflecting the progress that we're making across the group. And in particular, I guess for NHFT, moving the Northants MHLDA into phase 2, which is taking on more work, and we're going through the due diligence of that, and completing a joint workforce agreement, enabling the sharing of clinical and non-clinical staff between the East Midlands Alliance, the kind of key bits there. We've then had an initial conversation around strategy and planning, and we're going to pick up a little bit more of that in the private board section this afternoon in order to agree an approach and a way forward. And I think the last bit I was just going to pause on was just, we did have a really useful conversation about there is an awful lot of group learning coming out of conversations. And I haven't done the richness of the conversations from JWG that much justice today in terms of providing a summary. But we could see evidence in there about our ability to accelerate learning, how we were solving problems together, and that was giving us better problem solving, examples of innovation, a real focus on outcomes and ways forward. And also we were doing a good job where we could speak with a bigger voice. So we were reflecting that our profiles externally were increasing because people were seeing more going on. That in turn was getting greater recognition, which in turn increases our influence and ability to deliver change. So all of those things had worked through. A full AAA report will come back to the next board meeting, but we didn't want to skip today's without providing a bit of an update from the committee.
Thank you, David. Julia?
Thanks, David. Really comprehensive coverage, and also some of the benefits from the collaboratives, etc. We're looking at being able to share those in fairly simple stories, because to be able to share with anybody, either as non-exec directors or others, some of those benefits is really is key. So having simple stories, simple, benefits to patients, families, communities, etc., is going to be really useful. But that group learning, I think you're right, David. You've done well to capture it into a few points, but actually the discussion was very rich, and I'm sure more of that will come out. Again, simple stories about the level of learning that's going across these two organisations is just incredible, and so I'm sure there'll be a bit more detail to come. So thanks, David.
Thank you, Julia. And of course, just a reminder that Julia and Faisal are sharing the chairing of that committee, which I think is really helpful because it allows us to come together appropriately in that forum as well, but also recognise the individual needs of both organisations. So it's a helpful way of taking that forward. So thank you, everybody. We have now got to items for information, and of course paper N is our board declaration of interest register, which is as ever always there for information, and but just a reminder that we do need to make sure we're keeping that continuously up to date, so please do review that and make sure that it reflects your interests and it's up to date. Any other business? Now we have, I've not been alerted to any other business, so unless there's anything urgent, I propose we are nearly at a point of closing the meeting. We have come to ending the meeting somewhat earlier, bearing in mind there was a guest that we had originally planned to attend that wasn't able to. I do want to just mention that I am actually an apology for the private meeting, and Julia, and this was something she and I had planned. So Julia, in full anticipation of chairing the private meeting, I know you'll be very kind and supportive to her in her undertaking that role. So I just wanted to mention that. Having said that, can I just double check? The private meeting is due to start at 1:30. Our colleagues wishing, I'm always conscious that executive colleagues may have planned to do things at 1 o'clock or at other time, may have already scheduled some other things to happen in between private and public. So did you want to start earlier or do you want to stick to 1:30? I would leave that to you as members of the board to decide whether you'd want to start earlier, but how do people feel about that? Because obviously we could start at 1 o'clock if we wanted to. Anne?
Hi, Krishni. I've been in and out because it's been a bit stretched in the system. They've just put a surge meeting in for myself, Itai and Linda at 1 o'clock.
Okay.
So we'd have to go to that, I'm afraid.
No, that's absolutely fine. And I was almost anticipating that, Anne, in the circumstances. So I was only suggesting it in case it was convenient. But I think I'm sure other colleagues would welcome a longer break. So the meeting is due to start at 1:30. As I say, Julie is chairing that. But before we close, apart from losing an item on our agenda, which obviously we will replan, were the items appropriate? Any feedback in terms of timings or any other issues that you would want to raise in the context of our agenda today that would be useful for us to take on board? Is everyone content with what we've covered today? Angela?
Yeah, I think just to say that I think it was well structured. Timings felt good, and I think we had once again a lot of ability to talk with services that came to present to us, and I think that was really valuable as ever. And the content of the reports I think is allowing us to get the right timings and the structure of the agenda, so I thought it worked well today.
Thank you, Angela. That's helpful. And as I say, I think it's really obviously allowed me a little bit more flexibility on timing, so I didn't worry too much about the service story. But it's worth mentioning that conversation that Anne and I had, albeit on email, I think, Anne, just about actually using our patient story as a way of sort of telling us, helping us understand the service better, but also the staff experience as well as the patient experience, because I think we've long accepted that the staff experience really does contribute to the patient experience, so the two are inherently linked. So I felt that came across really well today and gave us a really comprehensive picture of what's been happening in our memory assessment service. So that's really good. And then Richard, please.
Thanks, Krishna. Yes, I was just going to sort of profile the additional question that we've added into this snapshot review on equality. And just to note, obviously, that we've had quite a bit of discussion, actually, not just on equality, but also health inequality today, which was certainly very, very welcomed. And I think will be a feature as we go forward, particularly in light of the new duty in terms of having regard to the impact of our decisions on health inequality. So really, I'm sort of profiling that particular question as something new in case board members hadn't spotted it, but also remarking on what I found a very useful conversation actually today on equality and inequalities. Thank you.
Thank you, Richard. And Melanie, finally.
Yes, just an idea which you might wish to consider. I was reflecting on this being a public meeting and the patient and service stories that we have. I think it might be helpful to members of the public who listen for us to maybe just include at the start of that story as to what the service is and kind of where it sits. Because I think sometimes we launch in assuming that everyone knows that what a memory service is and where it sits in the trust, whereas in actual fact, I'm sure for members of the public it might feel at times not quite as clear as it does to us. So maybe that's something we could consider in the future, just a bit of an intro on the service itself before we go into more of the detail, because it's such a wonderful feature and so helpful for us. So
Yeah.
just an idea.
Really good point, Melanie. I think we always need to be mindful, particularly because, you know, people will watch this afterwards, and I do know people watch it afterwards, and also our governors will undoubtedly, particularly because we tend to signpost them to the patient story. So in terms of that introduction, I think that's really helpful. So Anne, I can't think of a more perfect person to do that introduction than you. So if you could just think about that in in the way, you know, just by setting a scene really of you know, the where it sits in the older adults services, etc. I think that'd be really helpful. Annie, you're comfortable to take that forward?
Yeah, absolutely. I just think we're just getting into the rhythm of it being, I know we were used to it in COVID, but it's very different to doing a patient story in person. And I think we've had to get used to those changes because being online is a very different thing. So yes, any other comments, please come back to me and we can update. But yeah, happy to take that forward.
Thank you, Anne, and please thank our colleagues who came, because it was really interesting item, and I think really helpfully for me reflected you know, I mean, clearly there's a lot more work to do, isn't there? And I think Farida highlighted that actually, you know, we're looking for better outcomes for our patients, but what that provided was really good evidence of our commitment to improvement. And for me, that was the really important point that came across, is the work we're doing to try and improve the service we provide to our patients and the experience they have. But there's so much more to do, and I think that was recognised as well. So it was a really good illustration. So thank you, everybody, and reconvene at 1:30 with Julia in the chair. And as I say, well, I hope you have a good private meeting. I'm just happen to be attending a regional meeting this afternoon. So thanks, everybody, and have a good meeting. Thank you.
Thanks, Krishni.
Thank you.
Bye.
Bye, everybody.